going to talk about the utilization of critical care paramedics in the aeromedical industry. This talk was originally made for respiratory therapists, so there are some minor deviations. As far as my style of teaching, and ask questions all you want. If you have to go smoke, go pee, whatever. Pretty laid back. So I guarantee you this is in every one of my presentations. And what you're going to find out through today is I only have one presentation. I just rearrange the slides and tell it in a different order. You guys are going to be working side by side with paramedics, nurses, firefighters, physicians, respiratory therapists. They're going to say, you know what? I've been doing this 5 years, 10 years, 15 years, 20 years, 30 years. I have seen it all. I have done it all. Is that true? October 1st is my 17th year with Flight for Life. Somewhere around 2,200 flights. I guarantee you, every time that phone rings, every time that pager goes off, I still get the heebie-jeebies. You have no idea in the world, much like your line of work right now, when that pager goes off, you have no idea what you're going into. And the coolest thing about this profession is you guys get reminded every day how much you don't know. Medicine changes every day. You're never going to know it all. This was from when we just put a bunch of new nursing recruits through our transport team. This is what one of the guys said is, welcome to transport nursing, 90% boredom, 10% sheer terror. If you ever have that attitude, go sell shoes. You know, for me, it's 100% sheer terror all of the time. Like I said, things change constantly. Hopefully today, after my talks, you guys won't be in this situation. So I've been awake for like going on, I think, 3 days now, so maybe I will be. But as far as transport medicine goes, again, you always want to be the one giving the patient off. You don't want to be on the receiving end of it. So probably the most common question that I get is, you know, do you have to go to school to do that? It's like, no, the funny thing is, you know, I was walking to Taco Bell to do my, you know, drive-in shift, and some guy said, hey, you want to go fly in a helicopter all day? And I'm like, sure. Yeah, so as far as education, yeah, you do have to go to school. My initial dream was actually to be a guitarist out in LA. And wound up going to work with my sister one day, who was a pediatric respiratory therapist, and she was working specifically with the cystic fibrosis patients at that time. So as far as for pulmonary clearance, you would go in there and you would beat on these kids to knock the secretions loose. So I'm thinking, how cool a job is that? Go in and beat up kids and listen to Ozzy all day? Pfft, I'm hooked. So that was my true love. Is actually my original love is respiratory care, respiratory therapy, and then wound up, and at the same time I wound up going to RT school and EMT basic school at the same time. Loved them both. I absolutely loved the ICU, but I also loved the pre-hospital section of it. Wound up going back to paramedic school and getting hired by Flight for Life, but again started as an EMT basic, and then I met this guy here. This was the medical director of our pediatric ICU, a guy by the name of Bill Perloff, which everybody thinks that the P in pediatric ICU stands for pediatric. In all honesty, it stands for Perloff. This guy was an aeronautical engineer for a company that dabbled hand in hand with NASA. So I mean, literally, you've got a rocket scientist right there. And then in his mid-40s, decides, you know what, I'm going to go back to medical school. And in a very short period of time became a professor of anesthesiology, professor of pediatrics, as well as director of pediatric critical care, pediatric transport, all of this stuff. This guy, I am still eating paste compared to this guy, but this was my mentor. I've got countless stories about him that, like I said, just an unbelievable guy. And then my dream, I started at UW back in '88. My dream was always to have a designated pediatric transport team. It wasn't until the year 2000, when this goofball here started. A guy by the name of Tom Brazelton, and if you want to be a purist, he's actually T. Barry Brazelton III. So if you've ever heard of T. Barry Brazelton, the Pope of Pediatrics, that is his son. And anyway, we're at like 3 in the morning once we were talking about peds transport, and I'm like, you know, I've always wanted to do it. He's like, let's do it. It took us 4 years, but we wound up getting the pediatric transport team up and running there. And administration said, well, if you guys want it so bad, Tom, you got to be the medical director. Stu, you have to be the office monkey. So I get to be the day-to-day coordinator for the past 8 years. But it's formally known as CHEETA, Children's Hospital Emergency Transport Ambulance or Aircraft. And then, like I said, up until last year, I was working full-time down the road at Flight for Life, except I was down at the McHenry base, unless I was in trouble, and they sent me to Waukesha or Fond du Lac. And then just recently, last year, I switched back, and now I'm doing full-time pediatric transport at Madison. So as far as transport goes, a couple different modes: ground, air, and as far as air, that can be broken down into fixed wing as well as rotor wing. Probably by far the most common is ground. The reason being is It's the cheapest. As far as critical care transport goes, one thing that unfortunately we've got to get out of that mindset is pre-hospital care versus critical care transport. Pre-hospital care, we're taught get in there and get them from point A to point B as soon as possible. Critical care transport, you want to get them from point A to point B improved. So you just got to go into with the mindset of we are going to have extremely prolonged bedside times. If you wind up going in there and spending upwards of, there are times where we sit at the bedside for 2 hours making sure that our patient is stabilized. The last thing in the world I want to do is just come and grab and go, and all of a sudden I'm at 1,500 feet in the air with some kid that's crashing on me or an adult that's crashing on me with something that could have been prevented at the bedside. So like I said, we kind of have to get out of that mindset of just coming in there, grabbing and going, or scoop and go or whatever. It's more or less a stay and play attitude. As far as air goes, again, this is the one that everybody wants to do. And like Da Vinci said the best, once you've tasted flight, you will walk the earth with your eyes turned skyward, for there you have been and there you will always want to be. I fly down in the Chicago area, so very routinely we wind up heading up and down the coast of even over the good old Bears Stadium, which wouldn't be illegal to urinate out of the helicopter. I probably would. And then there is fixed wing transport. And generally, as far as rotor wing goes, generally you've got about a 250-mile radius. Once you exceed, as far as the utilization of the helicopter, once you exceed 250 miles, generally it's a lot cheaper to go by fixed wing. And as far as fixed wing goes, you have no idea where you're going to wind up. At any given time, there are countless fixed wing aircraft flying patient flights throughout the United States. A couple years ago, I was called to do a flight. Or asked if I'd assist on a flight. Well, come to find out, it was from Dubai to San Francisco. And I've got a friend that works, and she said, yeah, in one 24-hour shift, she wound up seeing both the Atlantic and the Pacific Ocean, that she wound up going coast to coast for 2 different patient flights. So again, there's no telling where you're going to wind up. But again, rotor wing, like I said, probably the most common, first started in the Korean War and then the Vietnam era war. Again, is when they really noticed the benefits of air medical transport utilizing helicopters. First state program was out in Denver, Colorado in 1972 when they had the Olympics out there. They had to figure out a way to get people off the mountain. And so the first original Flight for Life was out of Denver, Colorado, and that's where we actually stole our name from. As well as there are many transports where in the course of one transport, you might do 2 or 3 different modes of transport, where you might go pick up a patient by ambulance, take them to an airport, go by airplane now, to some other airport, and then go by helicopter to a hospital. So you just need to throw in a boat and you'll have all 4 different modes there. As well as there are specialty transports, which we'll talk about in a little bit also. As far as neonatal pediatric transports, again, this is a completely different world. And this has been out there for decades. We just started our pediatric transport team in like I said, 2000, 2004 in Madison. And we think, well, we're on the cutting edge of technology. Again, this has been going on for decades. There is nothing new about any of this. And again, as far as PEDS transport goes, again, it's getting more and more specialized, as well as it's basically a moving billboard for a lot of these children's hospitals. As far as transport teams, this is something that you've really got to think about. If this is something that you truly want to do, you have got to do your homework on where you want to work. Do I want to work at a busy program where I'm sitting there flying all day long? I would love that. But what's more important than being busy? Being safe. Definitely do your homework on those programs. A couple different types of ways to fly out there. There's what is called VFR, which is Visual Flight Rules, which means you have to be able to see where you're going in order to fly. And that's currently where Flight for Life, that's where we're at. We are a VFR program, meaning we have to see the ground if we're going to go flying. And then there's also IFR, which is Instrument-Rated Flight, which means if it is cloudy out, if you can fly by the instruments of your aircraft, so fly above the clouds. And this is kind of what this is depicting here is, hey, what's a mountain goat doing way up here in a cloud bank? Well, what's going to happen here in 2 seconds? Yeah, they're going to hit a mountain. So anyway, and we're in the infancy of going IFR with that program. That does not mean that just because we're an instrument program, we can go flying in every weather, all types of weather. Again, we're still extremely limited, and it's basically for inter-facility flights only. It's not like you guys can give us GPS coordinates to a scene flight in bad weather, and we're going to sit there, pop up, and come over and fly to your scene in bad weather. Again, it's pretty much for inter-facility only. There is what is called CAMES, which is like the Joint Commission's version of the Good Housekeeping seal of approval for air medical programs. That this is pretty much what we would like to see is that every program out there is accredited meaning that they've got, they dot all their I's, cross all their T's when it comes to safety stuff, as well as protocols, as well as all of their FAA stuff. That being said, unfortunately, these days, it's getting to the point where the industry is getting somewhat diluted now. More and more and more and more programs are becoming certified that you really kind of wonder the value of it anymore. Unfortunately, this was also one of the early attitudes in this field, is you know what, you guys are self-loading baggage. Get in, sit down, shut up, and hold on. These days, again, if you're part of that air crew, you are definitely part of that air crew. You have got just as much of an equal say as the pilot. So, and we'll talk about that here in a little bit too. It's called what it's called is crew resource management, where if something is wrong, you've got to say something. So as far as the whole CAMES requirements and stuff, unfortunately these days with critical care transport, specifically rotor wing transport, it's becoming a business. We are seeing more and more and more and more and more programs out there. Several in the mid 80s, there was 275 air medical helicopters in the United States alone. Today, any idea how many there are? Hair under 1,000. What about here in Wisconsin? So in 84, the first air medical program in Wisconsin was Flight for Life out of Milwaukee, followed shortly thereafter by MedFlight in 1985. Today, I think we have got 10 air medical helicopters in Wisconsin. You go down to Missouri or Arizona, there's upwards of 30 or 40. And the joke was, they're going to be running into each other. What happened about 3 years ago down in Phoenix? They ran into each other. 2 air medical helicopters going to the same helipad at the same hospital at the same time. Phoenix, where they got crappy weather, what, one day a year? Yeah, they wind up literally crashing into each other, killing everybody on board. And unfortunately, like I said, these days it's becoming a business. The downfall is if you don't fly, you go out of business. There was a very very well-known call several years ago down in the South Carolina area, where there was a ground crew that called for a helicopter. They had a pedestrian struck by a motor vehicle, had a isolated tib-fib fracture. Called for the helicopter. The first helicopter said, "We're not doing it because of weather." They call another program. "We're not doing it because of weather." They call a third program. "We're not doing it because of weather." They call a fourth program, whose numbers are kind of low. What do they say? "We'll do it." So they fly out there. They pick up the patient in crappy weather. They take off shortly thereafter, crash, kill everybody. Where again, you don't fly, you go out of business. I would much rather go out of business than wind up like this. So this is what I was talking about: crew resource management. This is something that's nothing new. We stole this from the airline industry, where again we've got what we say is 3 to go, 1 to say no. So you got the pilot, you got the nurse, and you've got the flight medic, the flight paramedic, the flight RT, the flight physician, whoever. Everybody has got an equal say. If you don't like something, speak up. If you don't want to go on that flight, well, I shouldn't say if you don't want to go on that flight. If it's 10 minutes before the end of your shift and you got a hot date, you can't sit there and say, "We're not going." But if something bothers you about that call, speak up. No questions asked. And that's something, again, when you go and apply for a program, ask them, how much is my opinion worth? If we wind up taking off and I don't like what the weather looks like, if I sit there and say, "You know what, I don't like this, turn around." Am I going to get fired, or are you going to sit there and turn around? And we even expanded it to 4 to go, 1 to say no. We included our dispatchers. At our dispatch center, they've got the big animated weather. And if the dispatcher's looking and saying, "You know what, you're taking a flight out to western Illinois, they're having thunder showers out there and tornadoes on radar. You know what? Don't go. Turn around. We're not even going to dispatch this." So again, 1 to go, or 3 to go, 1 to say no. And again, if you don't like something, again, you've got to speak up. And it might be something as simple as, where are we landing? If I was on that helicopter there landing on a dusty ball field, do you think I'd want to sit there and say, "Oh yeah, go ahead, keep on landing"? Oh, hell no. No. Turn around. Weather, same thing, especially in this neck of the woods where, in good old Wisconsin winter, we say, Wisconsin's got, 11 months of winter and 1 really shitty month of skiing. It changes constantly. And again, something like this, we can fly in the snow, but if it's a real blizzard, again, we don't want to be out there. Where we fly out of in McHenry Base, we're kind of down in a little bowl, kind of in a valley, where we get fogged in. And same thing, how well do helicopters fly in fog? Yeah, ask Steve Ray Vaughan about that. Not too good. So again, you got to speak up. And on the door going out to the hangar, out to the helicopter, It's something that I stole from the program over in London. It says the least experience, press on, while the more experience turn back to join the most experienced who didn't take off in the first place. Again, you know, in any time we accept a flight, well, I shouldn't say we accept a flight, anytime the pilot accepts a flight, and that's something that also you need to know, is that when a flight request comes in, we only tell the pilot, hey, can we get from point A to point B? We don't tell them, him or her, that, hey, you know, a little child got hit by a bike, and if we don't fly him, they're going to die. All they know is, can we go from point A to point B? That's all they look at. Generally, we like to get off the ground within 10 minutes. However, if the pilot is still checking the weather, if it takes them 10 minutes to check the weather, again, should that be a big red flag? Yeah. Again, landing zone security, you know, these things are idiot magnets. If you land a helicopter, how many people come running? You know, same thing with landing on a scene. And this was actually taken from down by Las Vegas, where they wound up landing at a scene. And while they're just about ready to touch down, somebody drove around the police cars and the barricades, and the pilot tried to react and wound up rolling the aircraft on the side. So again, it's the attitude of trust in no one, which we'll talk about later. This was a fixed-wing airplane that hit a deer, and somebody said, well, was that in the air? Yeah, it happened the night of December 25th. Yeah, like no, it was the plane was taken off and wound up creaming a deer on the runway. So as far as crew configuration, by far the most common is nurse paramedic. Probably about 2/3 of the programs are nurse paramedic. Why paramedic? They are cheap. And I hate to say it, but they are cheap. With flight, when I first started, I was the only non-firefighter paramedic. Every one of our other paramedics were all full-time firefighter paramedics, where they would sit there, you know, they would get all of their benefits and everything from the municipality. And hey, now once, twice a month I can come fly in a helicopter, pff, I'm game. So as far as our stack of applications for paramedics, how thick is it? It is huge, because like I said, there are everybody and their brother wants to do it. Nurse, again, somewhat of a common configuration depending on where you are. And again, also I should say, the configurations also are somewhat determined by what type of flight that patient, or what type of flight that base does. You know, if you go out to Phoenix or Tampa, where they do an excess of 95% scene flights, do you want a paramedic on board? Oh, hell yeah. Whereas if I go down to central Chicago, the program down there, UCAN, out of the university, where they do 95% inter-facility flights, 5% scene flights. Do I want that nurse that just came out of an ICU, or do I want that, you know, that paramedic that, you know, and again, that makes a huge difference. And then nurse physician, only about 2 or 3% of the programs out there utilize a physician. And then nurse other, again, there are some programs out there that fly nurse RT for everything, as well as there's also the state of Maryland State Patrol. Probably the busiest air medical program in the nation. Trooper 2 is actually the busiest air medical aircraft in the nation. They fly single paramedic. That is a cross-trained state trooper. Laryngoscope in one hand, 9mm Beretta in the other. That is the busiest program in the nation. So, and again, they also utilize, you know, if they got a sick patient from a scene flight, they'll grab somebody off the ground and say, you, come on, get in, you're helping me take care of that patient. Which, again, take it or leave it. So as far as, again, utilization of paramedics, this is something that we're seeing more and more in the critical care transport environment, either by ground or air. And again, you guys, you're sitting in this class, you know exactly what it's all about. Just don't turn into this guy. I am begging you. Yeah, just because you go through this class, again, you know, you've got to stay competent in this stuff. If you look at this list of stuff on there, you know, you are talking about, you know, in some cases, years and years and years and years and years of study, as well as not only studying it, but doing it and staying competent on it. And that's one of the huge things. And again, keep in mind, I said that we've got a stack of applications a foot thick. Everybody has got ACLS behind their name. Everybody has got PALS behind their name. Everybody's got NRP behind their name, PEP, stable, blah, 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 blah. What makes you different? Why should they hire you over anybody else? And again, if I've got somebody that's got 3 years experience straight out of school versus somebody that's got 20 years out of experience or 20 years experience out of school, they might have the exact same initials behind their background. What makes you different? And it is what is called your competitive advantage. Why should I hire you over this guy or this girl or this whatever? With me, it was pretty easy. I had a physician actually that made me this name tag several years ago. And I'd be sitting in the elevator and have people sitting there looking down at my chest going, what the hell? So yeah, being a rocket scientist really helped me. So as far as what type of person do these programs look for, what makes you a good team member? Who's this guy? Stuart Smalley. What would Stuart Smalley always say? I'm good enough, I'm smart enough, and doggone it, people like me. Again, you have got to believe in yourself. You know, keep in mind, you guys are going to be transporting the sickest of the sick patients in many occasions, and a lot of times you walk into that outlying facility, and they sit there and say, oh, flight's here. What do? See ya. It's like turning on a light and all the cockroaches just take off. And they hand you this steaming plate of turds and say, there you go, it's yours. Again, you've got to, like I said, believe in yourself. What about this guy? You know who he is unless you live in a shoe, right? What would he always say? You know, my daddy always used to say, you can't expect a dog to use a screwdriver in the rain. It's like, what? Well, he doesn't tell you, yeah, daddy was a raging alcoholic, but you have got to get along with each other. And keep in mind, you're going to be working side by side with a partner, and it's much like wherever you guys come from, the ambulance, the fire department. Now, correct me if I'm wrong, but there's that person at the fire department or at the ambulance service that you absolutely hate, correct? Oh, hell yeah. Now imagine being 2,000 feet in the air with somebody with a patient that's crashing. At flight, my partner in crime, she was actually my believe it or not, she was actually my best man in my wedding. That's how close we are. And we've gotten into the back of an ambulance at each other's throats, and the fire department will sit there and say, so how long have you guys been married? Otherwise, we will sit there and run a code without saying a single word to each other, just because we know each other so well. But again, now keep in mind being stuck in the back of that aircraft with some jag that you cannot stand, and you've got a patient that is crashing, and you have to work together. Probably one of the worst feelings in the world. But you will find that person that you wind up, like I said, working with. Who's the old guy? The old guy over here is my dad, so I'm not talking about him. But this old guy, Lord Baden-Powell, founder of Boy Scout, took his name, the initials from his name, BP, coined the phrase, be prepared. Again, in your line of work, we try to be prepared, correct? With this picture here, which you're going to see it probably in pretty much every one of my presentations today, being prepared, what is wrong with this picture? Eye protection. Again, Susie Save a Life here just gets off some $6 million helicopter, but she is way too cool to wear eye protection. Long before you sit there and, okay, what is this? Are you doing straight?
A left-handed tool.
It's a left-handed tool. Okay, so since you just derailed the train, why is it a left-handed tool? How many lefties in here? That is exactly why it is a left-handed tool, because of you. What's your name?
Rachel.
Rachel screwed it up for all of us. The reason... No, I'm dead serious. The reason the laryngoscope is a left-handed tool is because of people like Rachel. I don't know how many people are in this class, 15, 16, whatever, it doesn't matter, to one. The majority of the world is right-handed. That being said, going in there sweeping the tongue out of the way, that's the easy part. What requires the coordination and the dexterity is going down there with the Yankauer, going down there with the endotracheal tube, or going down there with, god-awful McGill forceps. Like I said, that is the easy part, sweeping the tongue. Most of us are right-handed. Thank you very much, Rachel. But whoever said eye protection, that is it. Like I said, long before you take care of these patients, you've got to take care of yourself first. And I cannot stress that enough. You ever catch me on a transport with all my eye protection, I'll give you $1,000. Guarantee it. I'll give you $10,000 just because I know you won't do it. So like I said, we are so far ahead of the rest of the world in technology, but this idiot here is too cool to wear safety glasses. Go to the other side of the world. You got this guy, who at least has enough sense to sit there and take care of his eyes. So like I said, take care of yourself first. Going back to, and again, like I said, I have a lot of my presentations are, like I said, somewhat the same. So as far as medications, again, we'll talk about this a little bit later. Sedation and paralytics, you guys are going to be using them, but keep in mind when it comes to drugs, which I know you guys have talked about, with the sedation as well as the paralytics, keep in mind as far as the paralytics go, there is no better way in the world to get that Christmas card from Habish and Davis saying, hey, thank you very much for sedating and paralyzing my spontaneously breathing grandpa, grandma, aunt, uncle, and then failing to realize that you intubated the esophagus. Again, just because you have got the ability to use these things, you always have to go back to your basics, and I cannot stress that enough. This is from one of our transport nurses that put this on his Facebook page. Jumped over an 8-foot wall, and this is when he was doing a medical mission, jumped over an 8-foot wall to get to intubation equipment. When is it ever so incredibly emergent that you have to jump over an 8-foot wall to get intubation equipment? Why could you not sit there and bag that patient? Then sit there and go find a doorway to get through that wall, go have a cup of coffee, sit down for a couple hours, and then come back with your intubation equipment. I asked one of our transport respiratory therapists when we were doing our oral rotations, I said, would you sedate and paralyze your own daughter and maintain her airway? And she said, oh, hell no. And I'm like, okay, then why would you do it to somebody else? You know, I would love to sit there and say, you know what, in order to get signed off on utilization of paralytics, and keep in mind that you are, you know, as far as paralytics go, pancuronium, probably pretty Pavulon, somewhat of a common paralytic, that is the drug that they give in lethal ejection in some of the states that do allow you know, them to put, you know, inmates to death. In all essence, with paralytics, you are literally killing that patient and then promising them an airway. For those patients that already have an airway that you paralyze, you are promising them, you know what, I'm going to take care of your airway. If it comes out, I am going to take care of it. What happens if you can't fulfill your promise? You want to fight for the driver's seat. Unless you're flying, then you got to fight for the pilot seat. And again, with the transport team, I always told the ones in Madison, I said, you know, I'm going to sound like a real jag for saying this, but at least one time in your career, you have got to feel absolutely helpless. And so I had one of our transport nurses who she's like, you know, can I come fly with you someday? And I'm like, yeah, no problem. All she wanted to do was scene flights. Yeah, I cannot stand scene flights. Give me a interfacility flight any day of the week. I'll gladly do that. So she came down, loved it, absolutely loved it. She wound up getting a flight position at another program. They wound up going out on a scene flight, had a motorcyclist with an isolated head injury, neurologically did need his airway protected. And this guy is spontaneously breathing, but like I said, needed his airway protected. They sedated him. They paralyzed him. And then if you can read by the email, got my scene, got my intubation, got my cric, got my 2 needle decompressions, had my first moment of helplessness. Please call me when you wake up and need to talk. They have a spontaneously breathing patient. They sedate him. They paralyze him. They suspected bilateral pneumothoraxes. They wound up decompressing him bilaterally. They couldn't get him intubated. They couldn't get him cric'd. They had this spontaneously breathing patient that they literally watched die in front of her. Think that has screwed her up? Oh, hell yeah. Think she's got a new respect for paralytics? Oh, yeah. And like I said, I hate to say it, but you all have to go through it. And it's one of the worst feelings in the world, but just like I said. And this sums it up better than anything. This is going to end in a disaster, and you've got nobody else to blame but yourself. We started Sunday morning off years ago with this goofball that gets in a verbal argument with his wife and says, well, fine, I'm just going to blow my head off. So, ladies in the room, what does she say? Well, you know, honey, we just painted the wall, so if you could go outside and do it, I'd appreciate it. So this dude takes a shotgun outside, goes out there, blows his face off, gets all pissed off, comes storming back in. He lays down on the couch. His wife calls 911. A police officer gets there, assumes he is dead. Police officer takes a shotgun outside to secure the scene. Meanwhile, zombie boy gets up off the couch. Cop turns around. This thing is standing on the porch stoop. I would have shot him again. We get in the back of the ambulance. This guy's sitting up on the striker. This guy is self-suctioning himself with the Ancar. And they're like, oh my God, sedate him, paralyze him, tube him, tube him, tube him. I'm like, you know, wait a second. We're going to go about 100 yards that way, my partner and I, and we're going to talk for a little bit. If we did sedate him and paralyze him, and we couldn't get an airway in him, can you do bag valve mask to that? This was in the days of the combi tube. Can you do a combi tube on that? Let's throw in a King or an LMA. Can you do that? And then we're thinking, you know what, this guy, if he could talk, and he was attempting to talk, he would have had a Glasgow of 15. The trauma center was probably about 6 minutes away by air. And I'm thinking, what if we just go for it? And then I'm thinking, I'm scared to look at this dude sitting on the ground. What happens at 2,000 feet in the air when neurologically he deteriorates to the point that he can't maintain his airway? So our plan was, if and only if both of us can palpate his cricothyroid membrane, we will give it one shot orally, and then we'll go straight to a surgical airway. This guy, in all honesty, was the easiest intubation I've ever done in my career. Everything was gone. I could have sat there with my index finger and my thumb, picked up with my left hand, picked up his epiglottis, threw the tube in, and we wound up getting him intubated. We're all happy doing the Snoopy dance. We get down to the trauma center. After they took over the patient care, surgeon pulls us aside and says, "Do you guys know that you didn't do C-spine immobilization on him?" And I'm thinking, you know what? Wow, he is right. A shotgun wound to the chin, is there a potential C-spine injury? Oh, hell yeah, but we were so tunnel visioned on this that, yeah, we forgot all about everything else. And a couple of years later, my partner was down at a trauma conference in Chicago, and they had a plastic surgeon talk. He did a case presentation on a self-inflicted shotgun wound to the face who happened to be Zombie Boy. In his presentation, he had pictures of what he looked like when he hit the OR, or the ER, as well as what he looks like today after multiple facial fractures. So Sharon went up to the doc, and she's like, "Hey, man, I flew him." And the surgeon said, "Well, he signed off on all images for educational purposes, so if you want them, here you go." And so somewhere on my external hard drive, I've got a picture of what Humpty Dumpty looks like again today. But this is the stuff that you walk into. Again, they will sit there and say, "Oh, whoa, flight's here. Here you go. Hey, oh yeah, by the way, we just pushed the sucks, so here you go." Again, just be prepared. Every intubation I go into, in the back of my mind, it is going to be a missed intubation. When plan A doesn't work, that's why you've got 25 other letters, and I cannot stress that enough. And make sure whoever you're working with, make sure they know that, if this doesn't work, we're going to go right to plan B, right to C, right to D, etc., and make sure they know what those plans are. Don't sit there and look at each other and say, "Well, now what?" So as far as the utilization of again, critical care transport, on my motor, like I said, live in right outside of Madison and then drive to McHenry. I pass by 4 or 5 different hospitals on my way to work. What's the license plate on my motorcycle? My biggest fear is waking up in the middle of the road with some, raccoon licking the CSF out of my nose, and then getting taken to some, Fisher Price ER, and then, having some doc say, "Well, I remember placing a chest tube back in residency." Get me to someplace, these tertiary care facilities where they do this stuff every day. You've got to treat every patient that you deal with. Again, think of them as your own kid. And these are my little turd nieces. This is my little monster. Again, treat every patient like they're your own child. And again, as far as critical care transport goes, again, there are some programs that transport everything. So again, one call you might be taking that 99-year-old STEMI flight. The next patient might be some newborn. Again, as far as anatomy and stuff goes, we'll talk about that. Who's this dude? MacGyver. And again, you guys have seen it going from hospital to hospital to hospital. And as far as the compatibility of your equipment that you've got on your ambulance or whatever compared to what the hospital has, how many times does everything fit together perfectly? Never. So you have got to have a little bit of MacGyver in you, where on the fly you've got to figure out, how can I make this square peg fit in this round hole in a very, very, very short period of time. So again, you've got to have some MacGyver in you. Not as advertised. How many times do you get sent on a call? The patient sounds like they're stable, and all of a sudden you get there and they're this multi-system trauma patient that they're ready to code on you. Again, this happens countless, especially in critical care transport. You've got that patient that is supposedly stable, and all of a sudden you just walk in on this just mess. We went out on one that they said, yeah, it was a Friday night, 2 o'clock in the morning. Your patient's 17. They were rejected. They are unresponsive. So we get out there, 17, unresponsive, bar time. What are we thinking? Yeah, we get in the back of the rig, and there's this little unresponsive 17-month-old. Think we'd like to know 17 months versus 17 years? Is there a difference? Oh, hell yeah. So again, get as much information as you can. And again, if you're doing multiple different types of transports, we took off a couple months ago, and Medcom, or our flight com said, Wow, really surprised you guys got off the ground that fast for a balloon pump flight. We're already in the air. Do you think they told us originally that it was a balloon pump flight? Where do you think our balloon pump was? Yeah. So again, get as much info as you can. Assassins. I hate to say this, and I probably shouldn't say this, but I'm going to say this. As far as going out to some of these outlying facilities, in your mind, you've got to think of them as assassins. Their sole purpose is to kill that patient. Again, you have no idea what you're going to be walking into. How many times have you walked into something like this? And again, like I said, and it's going to be right when they sit there and say, yeah, we just pushed, sucks, good, flight is here, there you go. Or worse off, we just pushed the VAC. There you go, now you got 40 minutes. You just walk into absolute messes, just, expect the unexpected. Every time I walk in, if we're doing a patient that is intubated, an interfacility flight, or even a scene flight where the patient is already intubated, first thing I look for is, where is that mask? In my mind, that is an esophageal intubation until proven otherwise, until we can assess capnography waveform, bilateral breath sounds, negative epigastric sounds. Where is that mask? And again, right up there with my safety glasses, that is a very, very, very close number 2 as far as where is that and is it coming with me? And again, you've got no idea what you're walking into. Past couple of years, I was over in Ethiopia doing medical stuff, and the neonatologist, oh, you got to come to my ICU. I got to show you our new CPAP setup. So he drags me all the way to the 8th floor at their hospital. This is their nasal CPAP setup. It is a discarded water bottle that this guy dug out of the garbage. On the side here, you can just barely see it, but it's a little piece of medical tape, and in increments of 1 centimeter. The further down you stick the tube in the water, what happens to the CPAP level? It goes up. And this was their new CPAP setup. And I'm thinking, what the hell? And then I was like, well, wait a second. You know what? This is absolute right back to bare bones medicine. This is absolutely perfect. We carry this $30,000 ventilator that does CPAP, and they were doing the exact same thing with a discarded water bottle. But again, you've got no idea what you're going to be walking into. And again, you've got to figure out how you can make your stuff on the ambulance or the helicopter or the airplane configure to that. And again, you walk into some things where, in the back of your mind, just say, you know what, we are walking into a code until proven otherwise. And again, 80-90% of your respiratory assessment, as you guys know, is done just by looking at that patient. This dude here, does he look like he's in distress? Is this the patient that you have to go and throw the pulse ox on right away? What's it going to tell you? He looks like Keith Richards here shooting up with heroin. What about the cyanotic lady? Again, both of these patients, make sure that you know where your bag and mask is. Make sure you got vascular access, because this is a patient that you're going to want to be, like I said, protecting their airway long before getting them in your ambulance, helicopter, airplane. This little monster here, how's he doing? He's doing fine. He's holding his little Winnie the Pooh thing. The only issue here is if he takes a header over the side and he's got a head injury. Otherwise, he's fine. What about this guy here? Again, that floppy fish appearance. He's getting tired. He's flaring. He's gasping. He's got retractions everywhere. Is it possible to tell if somebody's in respiratory distress just by looking at their eyes? And again, you're going to walk into that kid that just hit a tree at the bottom of the sled hill. You get to that ER, and he is still all bundled up. All you can see are his eyes. Or you go to that scene flight. You're down there on your hands and your knees with your Maglite, and you look in the back, and all you can see is some kid's eyes. Once you get him in the ambulance, or you start undressing him further and further and further, does that kid look like he's in distress? And you would not believe how often they won't tell us, as far as our patient report, they won't tell us about the flaring, the gasping, the retractions everywhere. They'll tell us, you know what, he's got an oxygen saturation of 93% and his respiratory rate is 26. What does that tell me? Would I want to hear that, or would I want to hear, you know what, he is flaring, he is gasping, he is grunting, he's got suprasternal, subcostal, intercostal retractions everywhere. But so many times people will withhold information from you because, oh my God, I don't want to sound like an idiot over the radio and say the wrong terminology. If you can't remember the proper terminology, what are you seeing? If I sit there and say, hey, quick, go get me the fire putter outer. Do you know what I'm talking about? Yeah. So again, if I can't remember all of these, say, you know what, when this kid takes a breath in, I can count, I could eat soup out of his chest. It sucks in that much. Or I can count every one of his ribs when he takes a breath in. That tells me much more than a pulse ox and a respiratory rate. So again, right back to just basic words. Again, this little munchkin's fine. This one, again, same thing, floppy fish appearance, poor muscle tone, gasping, retracting, flaring. What's this little guy doing? What's that nebulizer doing? Nothing. Again, that's the equivalent to walking down the street to Lake Michigan and peeing and expecting to see the water rise. It's doing absolutely nothing. Instead, you got vascular access. Where's your bag and mask? Because you're going to have a kid that's crashing on you real quick. Who remembers these things? Why are they illegal? Much like she ruined it for all of us being a lefty, she ruined it for all of us. That is why they are illegal. But how's she doing? She is fine. She's a pissed off little 6-year-old because she's got a dart in her head. She is pink and she is pissed off. That is absolutely perfect. Pink and pissed off with attitude, especially in the pediatric population, that is one thing you love. She's pissed because, you know what? She's got a dart in her head. Again, we've got to break this down into awareness, recognition, and management. Anything that can go wrong will go wrong. Again, get in the attitude that during this transport, that endotracheal tube is coming out. That IV is coming out. That being said, what are we going to do? So again, awareness, recognition, and management. We are aware of what happens when somebody's intracranial pressures go up, correct? We're going to be able to recognize it, and then most importantly, we're going to manage it. So again, manage it. So again, right now she's doing fine, but just in the back of your mind, in this 20, 30, 40, 1 hour, 2 hour, 3 hour long transport, she is going to arrest on us. Have that in the back of your mind, have a plan, so when it happens, you guys just kind of shrug your shoulders and say, you know what, we expected this, so let's act on it. Matter of fact, we've got all of our equipment ready to go right now. Let's do it. Who's this guy? And you know, he sits there and he bitches and he bitches and he bitches at his son and all those other idiots that work for him about, you know what, this bike is due tomorrow. Get going, get going, get going. But you know what, he's offering a quality product in a very short period of time. This goes back to that attitude of, you know, stay and play or load and go. Again, just keep in mind as far as your bedside times go, we're going to be there for a prolonged period of time because we want to deliver this patient in the absolute best possible condition. If that means taking down that IV, how many times have you guys said, well, you know what, he's got a positional IV? Or how many times have you heard that? Do I want to take off in a helicopter or an ambulance with a positional IV? Is there such thing as a positional IV? It's either they work or they don't work. If I've got a positional IV, guess what? We're staying here and we're placing another IV. If I have to emergently give somebody a drug, what are the chances of that IV being positional when I want to give that drug? Probably pretty high. So again, the whole position, it's like, do they have a pulse or not? It's a yes or no. It's a yes or no question. So the positional IV, again, don't trust it. So as far as, like I said, getting back to Paulie, again, he's delivering a quality product, but he's sitting there trying to rush it. In the critical care mindset, you've got to get out of the EMS mindset, the load and go. You've got to sit there, you've got to take time. So like I said, you are delivering quality patient care. Who's this lady? Mother Teresa. Again, you guys are going to be just dealing with people that, you know, I don't want to sit there and say, you know what, they're going to die, but you're going to deal with some of these patients that, again, you're going to be taking the sickest of the sick patient. And again, as you know, they might sit there and say, you know what, you've got a surgeon holding an OR at that tertiary care facility. They want that patient there now, that dissecting aneurysm. Get them there now. But meanwhile, I've got this patient's entire family sitting right here. Is it going to kill me if I went up and say, you know what, everybody come on over here and say goodbye? Take your time. Let the families deal with that patient. So Sharon, I always tease her. I always say that she's Mother Teresa in Nomex. A couple of years ago, this guy here, Tom, his entire family was leaving Great America, the last big vacation of the season. And at about midnight, they get creamed by a drunk driver. His wife and his 4 children, plus the family dog, all die. Anyway, long story short is Sharon tells this guy, if you need anything, you know what, let me know. He winds up living in their basement for well over a year, just because this guy was just a mental wreck. So yeah, so she was actually the best man in his wedding before she was the best man in my wedding. But again, like I said, Mother Teresa Nomex pretty much sums her up. And again, like I said, you're going to be seeing some of the worst stuff either by interfacility or scene flights. Who's this guy? So how do we go from Mother Teresa to Snoop Dogg? This is probably the most important slide out of all of this. Snoop Dogg, you're going to find this hard to believe, but I'm not a big Snoop Dogg fan. All right, so yeah, Snoop Dogg and his Mr. T starter set there. Yeah, so he always sits there and he screams, hey, we're representing. You are representing. And like I said, I cannot stress that enough. When you're sitting there parading around in your flight suit and you're coming from that hospital or that flight program, you are a flying billboard. You are on stage, and I cannot stress that enough. And as far as coming and picking up a patient for that hospital, you are the first contact that patient has with that. You are the first hospital contact that family has with that hospital, is that flight crew, that transport team. If you leave a bad impression, what are they going to think? Long before that child, that adult even gets to that hospital, they're going to sit there and say, wow, the transport team coming from that hospital was a bunch of jags. Do I want my loved one going to that hospital? Again, you are on stage all the time, and I cannot stress that enough. You've got to think about this constantly. Who is my audience? So on the early part of the slide, it said the other NCA. Everyone always said, well, what does NCA stand for? In many people's mind, this is what we are thought of as Nomex covered a-holes, because there are programs out there that will go to that outlying facility and they will tell them, oh my gosh, look at why didn't you guys do this? Why didn't you do that? Or they will call report right in front of that referring facility, and they'll say, hey, you know what? They almost killed another one. We came here and they've got this running where they should have, and they gave, this amount of a drug. Again, you get some of these small town hospitals, they get 1 or 2 sick patients a month. Now they get somebody that pushes them over the edge. Is it going to do them any good if you sit there and come in and sit there and belittle them? So again, and there was a program that was out west that every day, with technology, they put their flight crew online. This is who is flying today. And there was one nurse that was just such a biatch that people would sit there and say, okay, hey, we need this patient transported, but Nurse Ratchet is working, you know what, we're going to send it by a different program, or we're going to send it by air. Again, unfortunately, this is how many of us are projected. So like I said, really think about how you are. So as far as the transport team member, how are we looked at? Hey, we're the heroes, right? You give us anything, we'll take care of them, we'll save them. The receiving staff, again, we take these patients that are pretty much on death's door, and they're like, well, why'd you bring them here? Administration, we're a bunch of crybabies, want absolutely everything. The pilot, you are self-loading baggage. You know what? You're a sandbag. How much do you weigh and where are you going to sit? That's all they care about. And probably the most important slide of all of this presentation is their family. What's missing? This is something that, again, a lot of people, this is all they want to do is I just want to, I want to fly, I want to fly, I want to fly, I want to fly, I want to fly. And unfortunately, when they get that chance to fly, what do they forget about? Everything else. And you just get so sucked into this industry. And like I said, I cannot stress it enough. Don't get stuck in that situation. I did. I'm one of those people. 5 minutes before I was walking down the aisle to get married, I was answering some bullshit text about a transport. 2 minutes before my son was born, same thing, I'm on the phone talking about transport crap. Again, don't get sucked into this. And again, it's something you want to do so bad, and then they call you and they say, you know what? Hey, so-and-so just called in for Thursday. Thursday is your only day off. What are you going to say? I'll be there. I was just telling Mark, I said, the filter is probably going to be off today because I'm on like 48 hours of no sleep just running from place to place to place, because I'm one of those idiots that can't say no. I'm slowly learning, but like I said, know what's important to you. So as far as the types of flights, interfacility, again, taking a patient from a community hospital to a tertiary care facility, generally a level 1 trauma center for the scene flights. However, there are specialty centers, be it ones that, burn centers, places that do offer hyperbaric therapy like St. Luke's or wherever. Scene flights, again, depending on where you work. Here in the Waukesha area, it's about probably about 20-25% scene flights. The rest are interfacility. Once you get a little bit more rural, the scene flights increase. Specialty flights, again, we do balloon pump flights. As far as organs, we'll go pick up a team that just harvested organs on a patient, and then we're taking them to a transplant center. Training flights, again, if you don't do something, you get rusty at it. So again, especially with the pilots, they do a lot of training flights, and especially these days when, like I said, we're going to be going to instrument flight. Again, it takes a lot of training in order to stay competent. And then marketing flights. As far as the ABCs, again, you've had this drilled into your mind, into your head since day one. I always break it down into the adult ABCs, always bring camera. Pediatric ABCs, apnea, bradycardia, coroner. And as far as ABCs on kids go, this little munchkin, oh, he looks fine. Isn't he cute? Sit there, oh, take a picture of him. In the back of his mind, what is he daring you to do? Look away. Look outside the window. Kids don't give you any advance notice that they're going to crash. He can't sit there and say, you know what, hey, mister, it's getting harder and harder for me to breathe. When he has a respiratory issue, what happens to his heart rate? It drops like a rock. So again, pediatric ABCs, apnea, bradycardia, coroner. If you have a bradycardic kid, get right back to their airway. And like I said, in a matter of seconds, look out the window, and I guarantee you, kids do really bad things in a matter of seconds. So as far as scene flights, again, you pick up some of the, I don't want to say the dumbest of the dumb, but and the theme song from the Dukes of Hazzard is supposed to be playing here, but for whatever reason it's not. So that Porsche had 46 miles on it when that picture was taken. When I was talking about being on stage, I got gas once, and I was heading to work, or coming back from work, and I was still wearing my flight suit, and I got gas, and the lady behind the counter said, "Oh, are you a pilot?" And I was like, "No." I said, "I work in," and she goes, "Well, what do you do?" And I said, "I work as a flight paramedic." "Well, what's that?" And I said, "Well, we just fly around in a helicopter and pick up idiots." And she just kind of sits there and stops, and she goes, "Yeah, my boyfriend was flown last year." I'm like, "Okay." I'll just stop there. And so as far as PR flights, marketing flights, again, this is something that, as far as utilizing the aircraft, this is something, just again, going back to education. We do a lot of education with local fire departments, local ambulance services, especially as far as utilizing the aircraft. What are some of the indications you should be calling us? As well as with the fire department, you're the ones that are responsible for setting up our landing zone. So every year we go from fire department to fire department. And about this time of year, because we know our busy season is coming up, and again, just give them a refresher on setting up a landing zone. And especially if they don't utilize the aircraft that often, it's good to have a refresher. But again, helicopters are idiot magnets. You land a helicopter, who comes running? Exactly. Yeah. So again, a lot of PR, a lot of marketing stuff. And again, you get some of the most bizarre questions at some of these PR events. This is probably the most common question we get. "Can I have a ride?" It's like, "You want a ride?" They're like, "Yeah." And I'm like, "Well, go do something stupid and we'll give you a ride." Or else, "Yeah, my cousin, my uncle, my sister, my dad was a gunner in Vietnam." That's the other big common one. And as long as there are no administrators here from Flight for Life, and again, what do you guys do when you're not flying? That's exactly what we do. So no, when we're not flying, again, depending on where you work, when I first started at Flight, we were considered part of the emergency room staff. So when we weren't on a flight, we were out in the air doing stuff, which was nice because you could stay competent in IVs, you could stay competent in intubations, you were constantly busy. But then again, we were their bitches. "Hey, flight boy, go do this, go do that." And of course, when you're up on the 6th floor taking a patient, what happens? You wind up getting a call. So once our flight volume exceeded, I forgot what it was, 600 flights a year at that base, we got pulled out of the ER and we were made a designated flight. So again, depending on where you work, some places you might get stuck in staffing in the ICU or in the ER. There's constantly rotations going through the equipment, making sure that everything's ready to go as far as all your medications, all your equipment, again, make sure that it's not expired. Training, we are constantly doing training. These days with the simulation centers, again, at UW, if we're not on a flight or on a transport, we can go and hang out in the sim center and be a part of the simulations if those are going on. As far as cross-training, this is something that you either love it or you hate it. And when I first started at Flight, they said, "Well, here's the deal. We're going to be cross-trained." So I had flashbacks back from when I was a kid. So when I was a kid, I was the heavy equipment operator. That was mine, and that was mine. My brother, he was the dump truck driver. That was his, and that was his. If I ever had to pee, I'd just go running back here and I'd pee in the elderberry bush. If I came back, well, what was my brother playing with? Can you, now think about this. In all honesty, can you become a heavy equipment operator in the time it takes your little brother to pee? No, it takes years and years and years and years and years of practice. So again, when they said you're going to be cross-trained, coming from an ICU environment where we are extremely territorial, again, being an RT, and then going in, and they're saying, well, you know what? Yeah, well, here the medics are going to be, starting lines, pushing drugs. The nurses are going to be intubating, and I walked in on a nurse with a laryngoscope in her hand. Do you think I freaked out? It's like, oh, all right there, Gladys, put down the laryngoscope. You take care of the Foley, I'll take care of the airway. If it's below the diaphragm, I want nothing to do with it. But pretty much every program you're going to be working at, there is cross-training. And there is no better feeling in the world than knowing that, if I miss an intubation, which I will, I want another competent care provider to do it for me. So as far as cross-training goes, like I said, it's by far one of the best things in the world. Multitasking. Again, this is something that you're going to have to do constantly. Continuing education, again, we are constantly doing education again in order to maintain your PALS, your NRP, your ACLS, blah, blah, blah. You're just constantly recertifying and stuff. As well as a lot of times the flight crews get tapped to deliver education. This is from a couple years ago. We had a group of surgeons and pediatricians and ER docs from Ethiopia come over, and we taught them vent management and intubation in the pediatric population. And in reciprocation, we wound up getting to go over there and hang out in their ER as well as their ICU, which was one of the most eye-opening things I've ever seen in my life. On a regular 12-hour shift, you might have 6 to 8 pediatric full arrests come into the ER. And I was in the ER one day, and we were doing rounds, and they had an adult patient with a Glasgow of 3. And they said, well, what do you want to do for him? And I'm like, well, should we, let's intubate him and secure his airway. And they're like, oh, no, 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 no. He had his chance back when he was a Glasgow of 6 or 7 or 8. But now that he's a 3, over there, intubating somebody's pretty much a death sentence. You had your chance when you were a much higher GCS, because basically we were tying up a ventilator for some, I don't know if you can see this here. What looks like a stylet is actually that child's arm. But yeah, so I got to go hang out over there for a couple weeks in their ICU and stuff. And again, I showed you that. Community education, again, do a lot of stuff. Be it with elementary schools, junior high schools, as far as injury prevention, being bike helmets, all of that good stuff. Patient follow-up, again, part of the job is after we transport a patient, we will wind up calling back to that referring facility or that referring fire department and letting them know, how is that patient doing? What changes have they made? As well as this is a great chance for us also for education, again, and instead of at the bedside talking about not their mistakes, but what they could have done better is, just offer that up when you could give them a call back. Say, you know what? So the pediatric patient with DKA, I don't know how often you see it, but we've got several, lecturers here that, have got several canned pediatric DKA lectures. What about if we come out at your next team meeting and give you guys a talk? Specialty training, again, especially in aeromedical industry, it's pretty much mandatory that you do some form of survival training. Fire starting, how to create, build a shelter, how to field dress your flight nurse in case if you have to eat them, all that good stuff. And then again, know your limitations. Know when to say no. Just because you're now on the flight crew doesn't mean that you can take absolutely everything. Again, you've got to get a decent patient report. If something sounds fishy, again, you've got to say, you know what, let's just take a timeout. And as far as your resources, again, know what your resources are, know how to use them, and know how to use them correctly. Never, ever, ever burn alone. I cannot stress that enough. Know what your resources are, and there's no reason in the world, if you're flying out for something, or even on the ground, you're going out for that 5-year-old that just coughed his trach out and they cannot get it back in. There is no reason in the world you can't call your medical control and say, you know what, we're heading out for this. Just can you stay by the phone or stay by the radio in case we need you. That being said, who is your medical control? And what is their level? So with us on flight, our medical control, depending on which state we're flying in, is the emergency room physician. That being said, if I've got this patient that is on a balloon pump, they're in full-blown ARDS in pressure-controlled ventilation, which we'll talk about later, and I've got a vent question or a balloon pump question, and I call back to the ER doc, what are they going to do? Wrong number, wrong. So, and this is truly what it comes down to: find a job you love and never, ever, ever work again. No, we don't transport traumatic arrests. Well, we don't if somebody is coding, we won't fly them. We'll if it's to a scene, again, the chances of getting a traumatic arrest back is what? You know, less than 0.1%, 2%, something like that, whatever. So if that's the case, if CPR is in progress before we get there, say to a scene, we'll just turn around. However, if the patient is in our care and we're still in the ambulance and the patient arrests, then we'll go with those providers to the closest hospital, and then we'll have the aircraft come there. And as far as our traumatic arrest protocol, it's oral intubation, bilateral needle thoracentesis, and then pericardial centesis. And I've been on 2 flights where after doing a pericardial centesis, we got vitals back. That being said, the patient didn't live, but we were able to get them to the trauma center, and their family could come up and say their goodbyes and all that stuff. So, but for interfacility flights, if CPR is in progress, we don't take them. So there is more and more and more and more alphabet soup out there these days. So the first one was a critical care EMT paramedic, and then now there's the FPC, which is the certified flight paramedic. So, and Dr. Perloff, the guy that I showed you, many slides ago, he would always sit there and say, I'd ask him, I'd say, well, what about, PALS? And he would say, well, PALS and a cup of quarter will get you a cup of coffee. And basically what he was saying is, everybody has it. So now going back to that competitive advantage, why should we hire you? You got the exact same alphabet soup as everybody else. You know what? Since we are utilized so much in education, instead of having your ACLS, your PALS, your NRP, your stable, go back and get your ACLS, your PALS, your NRP, and your stable instructor card. You'll be so much more valuable. And especially for these flight programs that all these certifications are mandatory, we have to recertify in them every 2 years. If I've got so-and-so that's an instructor, do you think they're going to put him or her to work? Oh yeah. Get your instructor and all of that stuff. So the certified flight paramedic exam, I took it first in 2005 and swore I would never, ever, 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 ever take it again. That was the hardest exam I've ever taken. And now with CAMES accreditation, now we have to be certified. And I've just been dragging my feet because I've got to take it again and I'm scared to death. So, and again, many places, it is mandatory that you got it, or you have to get it within the first 2 years of hire. There is what it used to be called the NFPA, the National Flight Paramedic Association, that they had 2 different membership levels. One was called the associate member, which, hey, I've got an interest in air medical transport. And then there's the active member, where you are currently doing it. And it's a professional organization. And I signed up long before I was flying because I knew that was the direction I wanted to go. And back then they would send you a list saying, here's the minimum requirements to fly, here's the preferred requirements. I took the minimum requirements, pretty much tore it up and threw it away, and concentrated on that preferred requirement. If you go to a website called FlightWeb, one word, FlightWeb. So if you go to FlightWeb, and that's the site up there, flightweb.com. They do have a job center, and again, so there are positions out there, and just go to any one of these positions, and it'll sit there and it'll tell you what the mandatory requirements are. Generally, nationwide, it's about 3 to 5 years of pre-hospital experience, again, as well as all of that alphabet soup, your ACLS, your PALS, all that stuff. But I was going to say, if you go to the main site also, there's a section on there called links section. Click on the links, and they've got flight programs. And they've got them for Europe, they've got them from the United States. Click on the United States, they've got pretty much every state out there. And basically in the days of social media and technology, pretty much every flight program out there has got a website. And I guarantee you on the section there it says, you want to fly for us? Again, here's the minimum requirements, here's the preferred requirements. Again, do your homework, find out where you want to fly. If you want to sit there and do scene flights all day long, again, you're probably going to go down to Phoenix or something like that. But, with me, I wound up liking 50-50 early on, of scene versus interfacility. And like I said, over time that has changed significantly. Now the last thing in the world I want to do is a scene flight. Gladly do interfacilities all day long. But again, numerous programs out there have got a ride-along program. Where again, if it's something that you're interested in, sign up for a ride-along, go hang out with them for a shift. And that means pretty much any flight they go on, you go along with them. With the exception of if it's, say, a balloon pump or a specialty team flight or a long-distance flight where they need your weight for fuel, they won't take you. But again, it's kind of a neat section to hang out on there. As well as the FlightWeb forum. If you go to the general discussion area, this is probably one of the most common threads that's out there is, you know, I want to break into air medical transport. What do I need to do? And again, you've got people that have been doing this for decades out there that will give you numerous hints as far as what to do. There's actually a couple of these goofballs that have written books on what to do in order to get into it. So, like I said, you can spend hours out there on there. So, Flight for Life does have a ride-along program at all 3 bases. With the summer coming up, though, we suspended at the Waukesha base and the McHenry base just because of the heat, but Fond du Lac keeps it going, I believe, year-round. Don't quote me on that. So now let's talk mechanical ventilation. These are all fair game. These are all specifically in this region. These are all ventilators that you as critical care paramedics, you're going to be picking up patients on these ventilators. To you, everyone looks the same. To me, every one of these is a different monster that has got the ability to kill your patient quicker than you know. So I've been doing more and more event education. These were 2 of the emails that I received after that. Is first off, isn't there just a ventilator for dummies manual? No, there's not. Every patient is different. Every patient is treated different, especially when they're being mechanically ventilated. There is no cookbook medicine saying, okay, I've got an end title of 32, what do I do? Or this is exactly what I do. Blah, blah, blah. And then the other one is nice job, asshat. Now they're more afraid than ever to use the vent. Which I am fine with. You know what? I would much rather have you not use it than, you know, completely screw somebody up. And again, a couple of the old Perloff-isms. You don't know what you don't know. ACLS and a quarter will get you a cup of coffee. And knowing and not doing is like not knowing at all. So this lecture was specifically made for Flight for Life after we had gone to a different transport ventilator. And again, with flight at all 3 bases, we utilize a nurse-paramedic crew configuration. And with the paramedics, pretty much everyone except me is a full-time firefighter medic somewhere else. And I told them, I said, today, this is what I'm going to teach you. I'm going to teach you how to take that fire extinguisher and, you know, extinguish that big old pan of whatever it is. Tomorrow, this is what you're going to be expected to manage. For the nursey types, who remembers those things? Dial-a-flows. It's like the Fisher-Price IV pump, where you wind up rotating that and they got different orifice diameters in there, and basically that determined your drip rate. So today, this is what I'm going to teach you, is how to use a dial-a-flow. Tomorrow, this is what you're going to be expected to manage. As far as mechanical ventilation goes, this is the single most piece of equipment on your fill-in-the-blank ambulance, helicopter, airplane that has got the highest probability of killing your patient, but yet it's that piece of equipment that you get the least amount of training in. I cannot stress that enough. So as far as vents go, portable vents, transport vents, they have been out there for decades and decades and decades. Again, even down to these little single patient use Fisher-Price ones. But like the trend, everything gets smaller and smaller and smaller and more advanced. I was at a couple years, well, when I first started with flight, I was telling our marketing person, she goes, well, you know, would you be interested in doing education anywhere else? And I'm like, yeah. I said, oh, tell me where I have to go. So I wound up getting an email saying, you need to be in Kansas next week to do a mechanical ventilation talk. So I wound up going down to a flight program down there and did a vent talk down there. And I got a call at about 3 o'clock in the morning, and they said, hey, you deal with kids in trachs and vents all the time, don't you? And I'm like, yeah. They go, do you want to go on a flight with us? And I'm like, sure. So I was taking a patient from Omaha Children's Hospital down to Oklahoma City Children's Hospital by fixed wing. And anyway, during this transport, this child started waking up and started becoming asynchronous with the vent. And the receiving facility was adamant, we do not want that child reparalyzed. And so they said, well, you know, what should we do? And I said, well, I would would change the mode that you're ventilating in, and I would drop the rate. And they were like, do it. And I'm like, okay, I don't know this vent. I said, if I do that, I said, does anything else change? And the flight medic said, I don't think so. So that ventilator that we're using was very similar to this one up here. This is an old Servo 900C. So us respiratory nerdlingers, if you think about your cardiac output is comprised of what? How do we determine cardiac output? What times what? Heart rate times stroke volume. So us respiratory nerdlingers calculate what we call our minute volume the exact same way. Our respiratory rate times our tidal volume gives us our minute volume. So on these old vents, what we would do is we would set a minute volume. So here it's 7.5 liters or 7,500 milliliters. And we would set our breath rate. And between those two, we would wind up getting our tidal volume. So here we've got 7,500 milliliters being delivered in 1 minute over the course of 10 breaths. That being said, what was our tidal volume? 750 milliliters. So again, this vent that we're using in flight was very similar to this type. And I said, change the mode, drop the rate, but does anything else change? I don't think so. Long story short is we wound up dropping the rate, changing the mode. This kid's tidal volume wound up almost quadrupling as well as his inspiratory time. Keep in mind with many of these vents, you change one thing, you alter 3, 4, 5, 6 other parameters in a very short period of time. This kid wound up braiding down, and I'm like, this is going to be great. We're going to kill this kid. And again, it's my fault because I did something stupid on a machine that I was not familiar with. The other thing you need to know is, besides knowing your equipment, you need to know the limitations of your equipment. So I showed you this slide earlier. AeroCare, a fixed-wing international program out of West Chicago, the program director called me and she's like, are you familiar with the Servo I ventilator? I'm like, yeah, we've got probably 30 or 40 of them at UW. And she's like, do you want to do a transport for us? They had a 48-year-old patient with pulmonary fibrosis that needed to be flown out. Another fixed-wing program went in, and basically pulmonary fibrosis, that's 1 foot in the grave. Extremely difficult population to mechanically ventilate and oxygenate. And this other program went in with, again, one of these little transport vents. And this patient was maxed out on what the ICU ventilator could do, and they tried to match it on a transport vent. She didn't even make it out of the ICU before she crumped. And they took her back. Didn't even make it out the door. And the husband said she is not leaving this facility unless she is on a Servo I. So she called and she's like, can you do it? And I'm like, yeah. And then she tells me, yeah, it's from Dubai to San Francisco. If you could just calculate oxygen consumption for a Servo I going from Dubai to San Francisco, which just to get from Dubai to the east coast of the United States to refuel and get on more oxygen was in excess of 15,000 liters. Anyway, the patient wound up dying before we did the transport. And I'm like, well, we're still going to go to Dubai though, aren't we? But anyway, so most of the transport vents, again, they are the Ferrari events. All the bells, all the whistles, that's what we want. That being said, giving you folks in EMS or transport medicine anything expensive, what are you going to do with it? It's like taking grandma kickboxing. So yeah, okay, like vents, do you need all the bells and whistles, blah, blah, blah? Not really. So this is what we wind up giving you, something a little bit more durable. It's going to get you from point A to point B with the chest going up and down. That being said, you guys really aren't transporting patients that are healthy. Many times their pulmonary status is in the toilet. And again, is your little Fisher-Price vent going to be able to manage that? Probably not. So when we pulled the trigger and got transport vents at flight, they had asked, well, what do you recommend? And at that time, the LTV series, which I was very familiar with, I said, this would be my ventilator of choice. So who's this guy here? Sully from Monsters, Inc. So I asked one of our pediatric pulmonologists, Dr. Mary Schroth. She's a world-renowned pediatric pulmonologist. She uses that model vent, not only that vent, but there's a whole series of LTV vents. She uses those numerous times every week, invasively as well as non-invasively. And I said, what do you think about the LTV 1000? Quote unquote, it's a effing monster. She said it took me 6 months just to get the basics of it. And again, now they tell me, okay, if you could just teach our staff how to use this in 1 hour. Is that going to happen? No. One of my biggest pet peeves as far as why we don't use the vents, well, it's only an 8-minute flight. Is there such a thing as an 8-minute flight? Okay, maybe flight time is 8 minutes from the skids up to skids down. But the bedside to bedside time, that's what we need to think about. One of the absolute worst things in the world you can do for somebody that has been mechanically ventilated is take them off and bag them. Reason being, as soon as you disconnect that circuit, what happens? Basically, everything that outlying facility has gained as far as their oxygenation and their ventilation status goes, you just pissed away in a matter of seconds as far as disconnecting that vent. Even disconnecting them to suction them, if they're on a high level of PEEP, which we'll talk about here pretty soon. We'll see if this plays. So these are rat lungs. And what they're going to do is, so currently they're deflated. They're at what is called ZEEP, Z-E-E-P, zero end expiratory pressure. What they're going to do is slowly increase the PEEP, the positive end expiratory pressure, by 5 centimeters of water pressure. And what you will watch is you will watch alveolar recruitment, where these things slowly get more and more and more expanded. So here we've got big bands of atelectasis right here, which is just all collapsed alveoli. So you can watch the recruitment. Again, you've got just literally millions and millions and millions of alveoli that they're opening up. And then watch what happens when they disconnect it. So here we're at full recruitment, and again you can see those bands of atelectasis have been popped open with the positive pressure. There you go. Like I said, in a matter of seconds you go from basically completely inflated lungs all the way down to nothing. And on that patient that is in ARDS, again, that is one of the worst things you can do is disconnect them or suction them, because everything you had gained oxygenation and ventilation wise you just ruined. You just lost in a matter of seconds. And then you got to think about who's bagging that patient. So in the course of a transport, you might have the pilot. Again, if you're sitting there watching the lines and everything, or the monitor, trying to get something secured, you might say to the pilot, well, give the bag a couple squeezes. The security guard, hey, just give him a couple breaths. Or that nurse from that outlying facility that wants to come out and see the bird, they might wind up doing it. That being said, one of the nice things about the mechanical ventilator is it gives you a consistent rate, it gives you a consistent volume. Do you think all three of these people are going to be bagging consistently? That patient's minute volume is going to be all over the board. So this was taken directly from one of our charts. This is going from Kenosha up to Frederick. At 10:17, we'll manually ventilate the patient with a bag due to a short ETA. When they rolled into the neuro ICU, it was 10:58. Quick math, how long was that patient being bagged? 41 minutes. Is that a short ETA? In 41 minutes, they did no justice to that patient. This is a balloon pump flight. Again, so our crew winds up getting down there, they question the vent settings, and the outlying facility says, well, this patient is basically pre-ARDS. So what we're going to do is a high rate and lower tidal volume to decrease the chance of what's called barotrauma instead of hurting the lungs. Okay, so now you got a patient that's pre-ARDS. Again, they're on the fence. You've got a sick patient. And then in the next sentence it says, okay, now we hook them up to the oxygen, we're going to bag them. What good do we just do for that patient? Nothing, absolutely nothing. And again, knowing and not doing is like not knowing at all. The ultimate sin. So again, we've got this $30,000 ventilator that when we told the people that work on our helicopters, yeah, we need some type of bracket for it. They literally bolted it to the wall. So again, we've got this transport vent when the first time that patient is on the vent is when they're in the helicopter. Is that going to do any good? With transport vents, the best thing you can do is take your vent to the bedside. While you're getting a report, get your ventilator on that patient. See how well that patient is tolerating your vent. See how well they're oxygenating. See how well they're ventilating. Make any changes you need to do at that patient's bedside prior to getting out to that aircraft or ambulance. Because I would much rather do the troubleshooting at the patient's bedside before getting in the air. As far as the types of ventilation, invasive versus non-invasive, again, invasive ventilation, we're talking about endotracheal tubes, combi tubes, King's, LMAs, tracheostomy tubes. Non-invasive ventilation, we are doing more and more and more and more non-invasive ventilation these days. We teach you hours and hours and hours and hours how to intubate somebody. You're going to spend your entire career trying to figure out how to keep them from getting intubated. Given the choice these days, I would much rather do non-invasive ventilation. And as far as this lecture goes, it's somewhat specific to the LTV mechanical ventilator. So a lot of this stuff doesn't, and when I used to teach the critical care class, the one in Madison, I would bring in 6 or 7 different mechanical vents that we used in our ICUs. And we had a little heyday where everybody could sit there and go around from ventilator to ventilator and sit there and play with them. And the more and more I got to think of it, it's, you know what? You guys don't need to know our ventilators. You don't need to know how to run our ventilators. Whose ventilator do you need to know how to run like the back of your hand? Yours. So it's not going to do any good to sit there and bring, you know, all of ours in and say, okay, this is how they work. You need to know your ventilator, up, down, in, and out. So again, as far as non-invasive ventilation goes, multiple different ways to do it. You can do it via nasal mask. You can do it as well as adults also. As far as volume ventilation versus pressure ventilation, again, these are the two biggest animals. Again, we talked about invasive versus non-invasive. Breaking it down a little bit further, we're going to be doing volume versus pressure. In volume ventilation, your volume is always going to stay the same. It's your pressure that is going to change. So if I've got a trachea, if I've got lungs, if I've got a patient that is perfectly intubated, endotracheal tube is 2 centimeters above the carina, and we are volume ventilating that patient, I am putting I'm going to say if I'm putting in a tidal volume of 500 milliliters, I'm getting great chest expansion. And in order to get that 500 milliliters in, it's taking a pressure reading of about, I'm going to say 20 centimeters of water pressure, or you can use millimeters of mercury. They're pretty much interchangeable. So I'm volume ventilating at a tidal volume of 500 milliliters, and I'm looking at what's called my pressure manometer, my pressure gauge. And in order to get that 500 milliliters in, it's taking a pressure of 20 centimeters of water pressure. Now let's say that the stretcher stops or jerks, or the ambulance or aircraft jerks, and now I get a right main stem intubation. What's going to happen to my volume? And we're in volume ventilation. What's going to happen to my pressure? So now we get a big, nasty left-sided pneumothorax, exact same settings. What's going to happen to my volume? In volume ventilation. Stay the same. What's going to happen to my pressure? Again, we're putting a larger volume in a smaller area. What's going to happen to my pressure? It's going to go through the roof. So again, volume ventilation, volume always stays the same. The pressure changes. Pressure ventilation. So in volume ventilation, we are dialing in a specific tidal volume. And we'll get into that a little bit later as far as what size. Pressure ventilation, we are dialing in a pressure in order to get a specific volume in return. So if I am pressure ventilating a patient, that pressure always stays the same, and the volume changes. So same thing, now I'm pressure ventilating a patient, and I'm going to say that I'm ventilating them at a pressure of 20 centimeters of water pressure, and in return, I'm getting back a exhaled tidal volume of 500 milliliters. Same scenario, now I get a big right-sided, now I get a right main stem intubation. What's my pressure going to do? What's my volume going to do? It's going to decrease. Other scenario, big old left-sided tension pneumothorax. What's going to happen to my pressure? What's going to happen to my exhaled volume? It's going to decrease. So as far as alarms go, besides the vent settings, we're also going to be setting appropriate alarms. If I am volume ventilating somebody, it's going to be the high pressure alarm. That's the one that I'm going to kind of key in on, because anytime there's a change in my patient's volumes, or trying to get that pressure in, this is the one that I want to keep an eye on. If I am pressure ventilating somebody where my volumes are changing, it's going to be my low minute volume alarm. That's the one that I want to key in on. Whereas if I get a change in that, I want to know something's wrong. You know, do I have, and we'll talk about that here in a second. So a couple years ago, we were at a national convention, and I got dragged over to one of the vendors. It was Impact, who makes mechanical ventilators. And the chief flight nurse for flight, as well as the program director for UW, dragged me over different occasions and said, "You've got to come and look at this vent. It is so, so, so cool." anytime you get an alarm, on this little screen here, it lists off the top 5 or 10 reasons that alarm could be happening. And I'm thinking, are they serious? So imagine, and we'll see if this plays or not. Imagine if I'm taking off with the pilot, so if we have an alarm in flight, do I want my pilot to sit there with a manual and say, hey, could you tell me what that alarm means? If you're going to hang the shingle that you are this, fill in the blank, critical care paramedic, critical care nurse, critical care physician, critical care RT, I should be able to go up to any one of you and say, give me 5 causes for a high peak airway pressure alarm. You should be able to rattle those off, bing, 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 bing. Give me 5 causes of a low minute volume alarm. You should be able to rattle those off. You should not have to sit there and look at a book. Again, we were talking about this patient's airway, this patient's pulmonary status. Should you have to sit there and read something off a screen? No. High causes of peak airway pressure alarm on the mechanical ventilator in a transport setting. What do you think one of the most common causes is? Baby elephants. No, it's that patient coming out of their sedation and they're paralytic. The last thing I remember is I just saw, Skinner at Summerfest, and now all of a sudden I'm waking up in some helicopter. Do you think that patient's going to freak out if they got some tube in their mouth and they're trying to breathe against some machine that's trying to breathe against them and they can't talk? They freak out. A lot of times when your patient comes out of their sedation and they're paralytic, they freak out. Who said secretions are coughing? Again, where you get these patients, these patients that have, a severe pneumonia or something like that, this is a size 8 endotracheal tube. This is the patient that was emergently extubated in the trauma center over in Madison because we couldn't ventilate, we couldn't suction. So again, that being said, a size 8, how big a chunk of lung butter is that to completely occlude a size 8 endotracheal tube? So secretions, again, that's why the patient's hydration status is extremely important. Again, when we're mechanically ventilating somebody, we are bypassing that upper airway. So remember, the purpose of the upper airway is going to be to heat, humidify, and filter that inspired air. When I was a kid, I'd go out running in the winter, and my mom would say, well, you idiot, you're going to freeze your lungs. Are you going to freeze your lungs? Generally, within 25 thousandths of a second, your inhaled air is heated up to body temperature. So it's going to heat it. It's going to humidify it. In the course of 24 hours, you lose about 1 liter of fluid just by breathing. So again, without humidifying these secretions, what's going to happen to it? It becomes just like that. And then it's going to filter. Same thing. Well, when I was a kid, I'd be downstairs spray painting my guitars. Schwinn Candy Apple Red paint. 2 days later, I'd wind up picking my boogers. What color were my boogers? Specifically, what color red? Schwinn Candy Apple Red. So heat, humidifier, filter. So again, a lot of times prior to departing that outlying facility, ICU, ER, one of the things I always ask, have you suctioned them recently? If so, what were you suctioning out of them? If they have been suctioning them and they've been suctioned recently, good. If they haven't prior to departure, I'm going to suction them because I don't want to be doing it in transport unless I absolutely have to. Trauma patient, bilateral pulmonary contusion, big ol' occluded endotracheal tube, again, due to a big old blood clot. Who's that? So again, severe CHF, again, we're trying to put a volume in a space that volume just cannot go because it's so filled up with fluid, and in this case, just severe CHF. Is that going to cause the high peak airway pressure alarm to go off? Probably. Again, secretions, that's just a big old tracheal casting. What's going on here? You know what? We don't know. The best place in the world to assess somebody's chest rise is at their feet. And at this point, we don't know. It might be something as simple as a mainstem intubation. It might be a tension pneumothorax. We don't know until they wind up getting an x-ray. But again, something is not right there. And again, now we're trying to put a set volume in a much smaller space, which might create a higher peak airway pressure. We can be the cause of high peak airway pressures. Let's go back to this one. Basically, everything that everything medical that's put on a patient or in a patient has got some form of radio-opaque line on it. So again, here we've got the trachea, we've got the right main stem bronchus, the left main stem bronchus. The arrow here is going to be depicting the carina, or the bifurcation. You can just barely see a very faint white line here, which is the radio-opaque line on that endotracheal tube. That being said, what's going on here? You've got a right main stem intubation, which is something that we see all too often. And there have been times we've gotten in the back of an ambulance where you've got, Johnny Save-A-Life with a 14-gauge angio over that left chest, ready to decompress that chest for the suspected tension pneumo. First thing you want to do is look at the depth of that endotracheal tube. A good rule of thumb for absolutely everybody is 3 times the tube diameter is where it should wind up at the teeth or gums. So if I have a size 7, if I get in the back of the ambulance, they've got that patient intubated with a size 7, and it's at 28 at the teeth, and they want to decompress the left chest. What's the problem? It's probably too deep. And you want to use a anatomical landmark that does not change position. So some people will say lip to tip. That being said, when you guys wind up pulling somebody out of a house fire or pull somebody out of the car that just bit the steering wheel, what's going to happen to their lips? They're going to swell. So again, use the teeth or the gums. That being said, unless you live, or work way up in northern Wisconsin where they don't have the front set of teeth, then use the gums. What's going on here? Big old tension pneumo. And they always say that a chest x-ray of a tension pneumothorax should be a sin. Why? You should have caught it long before they snapped that chest x-ray. And my guess is the doc will probably say, you know what, we can't look at the x-ray now because we're coding this kid. So again, we're trying to put a large volume in an area where it just can't go. Again, you're going to get high peak airway pressures. Restrictive lung disease. So you can break down the lung disease into restrictive versus obstructive. Restrictive lung disease. You've seen these patients that have got the severe scoliosis, kyphosis, lordosis, where their spine is like a question mark or a pretzel. Again, no matter how much volume we put in that patient's chest, are we going to straighten out his spine? No. Or in the winter, when it's really, 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 really cold out, we wind up sitting there throwing them under our cot in that big old sleeping bag, and we sit there and we cinch the straps down really, really tight. What happens to their peak airway pressures? They wind up going up. Years ago, we had one of these little teeny boppers with the push-up bra. Her peak air, and she had normal pulmonary status, but her peak airway pressures were through the roof. It wasn't until they wound up cutting her bra that all of a sudden her peak airway pressures dropped by like 20 millimeters of mercury. So again, if they have any form of restrictive clothing on, take it off. Obesity. Again, in order to get that 500, 600, 700 milliliters into the chest, we've got to move those, all of that tissue. Another thing that can cause high peak airway pressures, this is something that we see quite often in the pediatric population, especially if we go to a small community hospital that doesn't deal with kids all that often. The size of the tube. Anytime you decrease the diameter of anything, doesn't matter if it's a fire hose, endotracheal tube, IV catheter, garden hose, what happens to the resistance? It goes through the roof. Now you go to some small town hospital that doesn't deal with kids that often, and they've got a 4-year-old that just arrests, and they say, well, hey, give me a tube, give me a pediatric tube. And they hand them a size 3.5. What do you think the pressures are going to be like? They're going to be pretty darn high. So, causes of low volume. And for extra credit, what movie is this from? Instead, Spinal Tap. Thank you. Instead, you're wasting your time reading the Brady textbook and all that other crap. You should be watching Spinal Tap. So if you've got a low minute volume alarm, the first thing you want to do is, get right back to that patient's airway. There is a possibility that the airway might be out. And again, looking at these kids here, both trach, do you think this kid here has any clue in his mind that his trach is out? Do you think he cares? No. Same thing here. But again, go right back to the airway, make sure that your airway hasn't become displaced in the transport setting. And again, just get in the mindset, if you're going to be transporting somebody that is intubated, have it in your mind that during this transport, that tube is coming out. I can't stress that enough. Same thing with your IV, it's coming out. The circuit itself possibly leaking if there's a small hole in the circuit. Again, air is going to take the path of least resistance, which is probably going to be out that hole. In the LTV series, the circuit hooks up in 4 different places, the main circuit area as well as these 3 little connections here. These are notorious for becoming loose and creating a leak. As far as the different modes of ventilation, multiple different modes. CMV, which is called controlled mechanical ventilation, this is like the first mode of mechanical ventilation ever. And then from there it was broken down into assist control, both volume and pressure, SIMV, both volume and pressure, non-invasive positive pressure ventilation, or BiPAP, pressure support, CPAP, and we'll discuss pretty much all of these here. So controlled mechanical ventilation. We rarely see it anymore. However, there are some dinosaurs out there that still use it. And again, you might do a transport from small town, from some small town hospital that, the ER doc, from back in residency, this is what we always use, so this is what we're using. Basically, it's going to deliver a preset tidal volume at a preset rate at over a preset inspiratory time for every breath. Preferably, that patient's going to be sedated and paralyzed. So if I've got somebody, we're going to say on a, let's see if there's a better color marker here. Let's do this pea soup green. And again, besides thinking about the vent settings, we also want to do some math. If I've got somebody on a rate of 12, how often is that patient going to be getting a breath in a minute? Every 5 seconds. So every 5 seconds, this patient is going to be getting a breath. A breath, and in this case, tidal volume of whatever, 500, and our inspiratory time we'll talk about a little bit later. But this section here, this is what we call, that 5 seconds, that is what we call our respiratory cycle time. In that respiratory cycle time, that patient has got to inhale and that patient has got to exhale every time. And if that patient winds up taking any additional breaths, now let's say they wind up going from a rate of 12 up to a rate of 15. What happens to our respiratory cycle time? Now we go from a respiratory cycle time of 5 seconds down to 4 seconds. Now what happens if they're clipping along at a rate of 20? Drops down to 3 seconds. Rate of 30 drops down to 2 seconds. Rate of 40, 1.5. Where they have to inhale, they have to exhale. But in controlled mechanical ventilation, they get that breath every 5 seconds. What happens if that patient comes out of their sedation, they're paralytic, and they want an additional breath? In controlled mechanical ventilation, you're not getting it. So the next generation of modes was assist control. And that can be broken down into assist control volume and assist control pressure. However, in this region of the United States, it's more commonly called pressure control. And the way that works is, again, we've got the machine is going to deliver a breath every, whatever, again, if we've got a rate of 12, every 5 seconds, so they're going to get that breath. However, if they want a breath in between, the machine will sense it in a couple different ways. They will trigger that machine. In this case here, it is what's called pressure triggering, where that patient has got to inhale, create a negative pressure, the machine senses it and delivers a breath. And in the assist control mode, it's going to give them an additional breath at the exact same tidal volume that you've got dialed in at, as well as the exact same inspiratory time. And your inspiratory time is how fast is that breath delivered. So again, on one of our flights, this patient is on assist control, rate of 16, tidal volume of 500 milliliters. So that being said, are they in assist control volume or are they in assist control pressure? They're in assist control, sorry, you're right, assist control volume. 60% oxygen, 5% of PEEP, plus 5 centimeters water pressure of PEEP. And that's what's charted. The patient assists the vent with shallow respirations. Are they going to be taking shallow respirations? How big should every one of their breaths be? 500. So again, as far as that patient wanting a breath, a couple different ways to do it here. Either the machine will sense it by pressure triggering, again, where that patient has to create a negative pressure. These days, though, many of the vents have what is called flow triggering, where flow triggering, any disruption in the flow going through the circuit of that ventilator, the machine assumes it is it's that patient that wants a breath. That being said, any disruption in flow, which might be as simple as shaking that tubing, the machine is going to assume it's a breath. In the transport setting, do you guys move around a lot? You guys ever go on bumpy roads? So when we got those new ventilators, we had a patient on a Norcuron, actually we didn't, the Fond du Lac crew had a patient on a Norcuron drip. The vent was set at a rate of 12, but yet throughout the entire transport, this patient was breathing at a rate of 22. So can you overbreathe the vent if you're on a paralytic drip? And what it came down to is the sensitivity on the vent was set too sensitive, that any little vibration in that tubing, the machine assumed it was that patient wanting a breath. So again, make sure you know what type of sensitivity your vent has. And on the LTVs that we use, you can do pressure triggering or you can do flow triggering. The flow triggering is, anyway, make sure if it's flow triggering, make sure it's not set too sensitive. And like I said, on the LTVs, it's kind of backwards to the rest of the ventilator world where it's less is more. And it's an inside joke here because that's our mechanic called less anyway, blah, blah, blah. Anyway, so going back, if the patient is over-triggering the vent where you don't want them to, again, you're going to have to adjust their sensitivity. Or again, look at that patient. If it looks like they want a breath and they can't get it, chances are you have to adjust your sensitivity to make it easier for them to breathe. So again, assist control. There are some downfalls of assist control. So again, this was taken from another transport that they had done where a patient was on a rate of 12. That being said, what's my respiratory cycle time? 5 seconds, 5-second respiratory cycle time. We're going to say that, again, to make easy math, we're going to say that we've got a tidal volume of 500 milliliters and we have a 1.0 second inspiratory time. So that 500 milliliters is delivered over 1 second. So 1 second of my 5-second respiratory cycle time is chewed up by inspiration. How much time does this patient have to exhale? 4 seconds. And on many of the ventilators out there, you have to set your rate by your what is called your I/E ratio, your inspiratory to expiratory ratio. So if we have a 5-second respiratory cycle time, we've got 1 second of that is for inspiration. What's my ID ratio? 1 to 4. 1 part inspiration, 4 parts exhalation. And again, this is things that you need to think of every time you change the rate or you change your inspiratory time because your I/E ratio changes. So on this call, this was a patient that, an old COPDer that they wound up flying out. This patient was mechanically ventilated. They were on a rate of 12, giving us a 5-second respiratory cycle time. And when they got there, the patient's exhaled or their capnography was 63. So, normal 35 to 45, as they say. So there were 63. So are we breathing enough, or is our patient breathing enough? No. So okay, now what they wind up doing is they wind up changing him to a respiratory rate of 15. So now we just went from a 5-second respiratory cycle time to a 4-second respiratory cycle time. They didn't change the inspiratory time at all, so we still have a 1-second I time. What's our E time now? 3. So now we're at a 1 to 3. And so this patient is a COPDer. So they wind up jacking up the rate to 15 because we had an end tidal of 63. So they jack up the rate to 15, and now his end tidal goes to 74. Is that normal? No. So okay, now let's jack up the rate to 20. So now we're up to a rate of 20. We didn't change anything else. So our respiratory cycle time that started at 5 seconds now went down to 4 seconds at a rate of 20. What is our respiratory cycle time? 3 seconds. We didn't change our inspiratory time. So we went from a 1 to 4 I/E ratio to a 1 to 3 I/E ratio. What are we at now? A 1 to 2. What are those COPDers, asthmatics notorious for? Air trapping. So now all of a sudden our end tidal is 80. So now we jack up our rate to 30. What's our I/E ratio now? So now we've got a 2-second respiratory cycle time. 1 second of that is burned up by inhalation. You are at a 1-to-1. Our next end tidal would probably come back in the triple digits. So again, these are the patients that you want to drop their respiratory rate because these patients are auto-trapping, they're air trapping, they are hyperinflated. So again, we started on a rate of 12. What if I wound up dropping my respiratory rate down to 10? What would that do to my respiratory cycle time? It's going to increase to 6, and we got a 1 second I time, now a 5-second E time. Now all of a sudden our end tidal CO2 drops, and we think, well, that doesn't make sense because in order for somebody to drop somebody's end tidal, we think that we have to increase their minute volume either by increasing their rate or increasing their tidal volume, but yet I just dropped my rate, and now their end tidal goes down. Why is that? Longer expiratory time, and now these patients are able to finally exhale. So this population of patients, first off, the best thing to do is not even intubate them in the first place. Do non-invasive ventilation, your BiPAP, which we'll talk about a little bit later. One of the worst things you can do is intubate an asthmatic or a COPDer. And let me obnoxiously repeat that. One of the worst things you can do is intubate an asthmatic or a COPDer. But by dropping the rate, we increase their expiratory time, and now these patients finally are able to truly exhale. And again, many of these vents have got graphics packages on them where you can actually look and see that they are truly not exhaling down to baseline, where if they're autopaping, they wind up getting a breath before exhaling all the way down, and they wind up breath stacking over and over time. They wind up just becoming so incredibly hyperinflated. With SIMV, and the first SIMV was actually called IMV, which stands for intermittent mechanical ventilation, where basically you would get machine-sized breaths. However, in between, the patient could spontaneously breathe. The difference is, we'll be looking at the volume down here on the bottom. So your machine-sized breaths, if I've got a tidal volume dialed in at 500 milliliters, every machine-sized breath is going to be 500 milliliters. In IMV, in between, the patient can spontaneously breathe. However, the size volume of breaths that they take is dependent on them. They're the ones that set the volume. One of the downfalls of IMV, though, is if this patient was spontaneously breathing, and if they were at end inspiration, and it was for time for that machine breath to be delivered, what would happen? They would wind up breath stacking. They would wind up getting yet another breath on top of that. So then they came out with SIMV, which stands for synchronized intermittent mechanical ventilation. So the machine basically monitors that patient's spontaneous breathing, and it won't deliver that machine breath until they exhale their spontaneous breath. Again, can be used in a couple different modes. A lot of times we wind up using it when we wean a patient, when the patient is waking up, and we like them to do a little bit more breathing on their own. In the transport setting, though, how often are we weaning patients? Probably not. The only time I ever really change to SIMV in the transport setting is when I want to lower somebody's CO2. Whereas if they're waking up and they're in assist control, either volume or pressure, where every time they take an additional breath on their own, it's that exact same size breath that you've got dialed in. And if they're hyperventilating, you can take them out of the equation by sedating them or paralyzing them, but if I don't want to, I can change them to SIMV. And by them taking a few spontaneous breaths on their own, it's generally a lower tidal volume. And by being a lower tidal volume, it's going to be a lower minute volume. By being a lower minute volume, it's going to be raising their CO2 a little bit. But like I said, we really don't do it that much in transport. If you ever have anybody on SIMV or IMV, many of the ventilators also have what is called pressure support. And what pressure support does is it gives them a little bit of assistance to overcome the resistance of not only the endotracheal tube, but the circuit of the ventilator itself, to give them a little bit of a boost. And again, we'll talk about breath size here pretty quick. But again, if you watch somebody that's spontaneously breathing while they're being mechanically ventilated and they're taking spontaneous breaths in between those machine breaths, again, we have to think about not only their machine breaths, but now are they getting an adequate chest rise with the spontaneous breaths? And if they're not, we might have to add a little bit of pressure support. And we'll talk about the volumes here pretty soon. So as far as BiPAP goes, again, this is something that we're doing more and more and more and more of, is non-invasive positive pressure ventilation. And again, in all honesty, it's a pain in the butt. You know, you get to that outlying facility and you get this patient that, you know, it'd be much easier for us to just sedate her, paralyze her, and intubate her, and transport her intubated, but is that the right thing to do? No. So again, if we can maintain non-invasive ventilation throughout the transport, again, by far one of the best things in the world you can do for these patients. If you do work for a program that does use a LTV series ventilator, it's got to be a non-vented mask. So again, for the initial vent settings, I always ask, you know, first off, if they're ventilated, what's the first thing I'm looking for? Where's that mask? Where is that mask? That manually sustain mask. So again, ask though, what settings were you using? And again, was the patient oxygenating and were they ventilating? Again, apples and oranges, in with the good air, out with the bad air. Don't just ask, you know, what's their SAT? Think about the entire picture. How were they oxygenating? How were they ventilating? That being said, again, remember what we talked about these people here? Who are they? Assassins. Again, you go to some Pumpkin Hollow community hospital that they don't deal with ventilated patients all that often in the ER. There is no telling what type of settings you're going to walk into. There's a small community hospital northwest of Madison that they have no need for a ventilator in the ER. They have one that's leased. It sits out in the ambulance bay. It is literally shrink wrapped. As soon as they cut that shrink wrap on there and break the seal, they start to get charged for it. That being said, what is the last thing they want to do in the ER? Ventilate a patient. So, you know, okay, we'll be there in 40 minutes, and they are there for 40 minutes handbagging that patient. And on the rare occasion that they are on the vent, it is some of the most bizarre settings you have ever seen. And again, how many times have you walked into this? We already talked about that. Where's your mask? Already talked about that. Already talked about that. So as far as depending on the facility, there's a possibility that they might still be handbagging. Now we got to be thinking about some appropriate ventilator settings. And again, this comes into, there's no cookbook on this. Again, we got to be thinking about what type of patient are we ventilating. You know, do they have some type of obstructive process going on, some type of restrictive process going on? So the initial settings, we want to know what mode, what rate. Are we going to be volume ventilating or are we going to be pressure ventilating? Is it going to be a mode that pressure support is an option? How much oxygen, how much PEEP, what's an appropriate inspiratory time? It's a whole lot of math in a very short period of time. So exactly what is normal? So for machine-sized breaths, we like to see 6 to 8 milliliters per kilo. Early on, straight across the board, it was 10 milliliters per kilo. So if I had a 70 kilo patient, how big a tidal volume would they get? 700. If I have an 80 kilo patient, how big? What we had found out is historically over time, we were beating up these patients' lungs by what's called barotrauma, giving them too big, or volutrauma, by giving them too big of breath. So then we said, you know what, we got to decrease these tidal volumes. So now for a machine-sized breath, we like to see 6 to 8 milliliters per kilo. If they're in a mode of ventilation that offers pressure support, so on the LTV, the SIMV modes, if that patient can spontaneously breathe, we like to see 4 to 6 milliliters per kilo for their pressure support breaths. And ultimately what it comes down to though is we like to see, we use the ideal body weight, which we'll talk about here in a second. And then the corrected versus uncorrected. Which again, this is where you need to know your vent, as well as you also need to know kind of that patient's vent on the outlying facility. When you push those 2 milligrams of Midaz to quiet your patient down, what do you follow it up with? A flush? Why is that? To make sure that the medication actually gets into the patient's circulation. So as far as corrected versus uncorrected, there is still a large amount of ventilators out there. I've got my patient over here, that if I've got a tidal volume, if I want to give my patient a tidal volume of 500 milliliters, I might actually set the vent at 600 milliliters. And all of us respiratory nerdlingers, every ventilator circuit out there has got what is called and don't write this down because you're never, ever, ever going to need it again. I'll take worthless ventilator facts for 200, Stu. It is what is called your tubing compressibility factor, where us respiratory nerdlingers, we would have to calculate how much volume of that 500 milliliters that ventilator, and keep in mind that it is putting out 500 milliliters right here, when it exits the vent, we would calculate how much volume is lost in that tubing and then calculate, make up for the difference in the tidal volume. So if I wanted my patient to get 500 milliliters, I would set it to 550, 570 or something like that. Now again, where it comes into play with you guys is you might be picking up a patient at an old line facility that they're using uncorrected tidal volumes. Many of the new transport vents that you guys are going to be using is what is called a corrected tidal volume, where it's actually measured at the patient endotracheal tube, how much volume that patient is getting. That being said, if I wind up using that outlying facility's tidal volume, are you going to be giving a breath that's too big or too small? Too big. If I take their tidal volume of 550 and throw it on my ventilator, keep in mind that their ventilator's tidal volume is measured way out here, whereas a lot of the transport vents, they measure it right at the patient's endotracheal tube. And they are compensating, they're overinflating their tidal volume to make up for all of this volume lost in the circuit. Whereas many of the transport ventilators these days, that patient's tidal volume is measured at what is called the patient's Y, W-Y-E, at where it connects to the endotracheal tube. And again, this is where it comes down to you need to know what type of ventilator you're going to be using. Is it going to be corrected tidal volumes or uncorrected tidal volumes? But ultimately, all of this stuff, you know what it comes down to is, do we really care about all of these numbers in our line of work? Not really. What happens if I get out there and my patient is being maxed out at, if they're going by protocol, and they are saying we are delivering 8 milliliters per kilo, and you look at that patient and they've got minimal chest rise? What are we going to do? What if they're at 6 milliliters per kilo and they're getting a huge chest rise? So again, these are just recommendations, just numbers, and I absolutely hate numbers. Again, it's just a good reference point on where to start. But again, keep in mind, ultimately what it's going to come down for you folks in the transport setting is whatever we are dialing it in, be it 6 mils per kilo, 8 mils per kilo, are we getting an adequate chest rise? If not, what are we going to do about it? If we're getting too much of a chest rise, what are we going to do about it? So again, look at your patient. I cannot stress that enough. So ideal body weight. Again, what are we going to use for a tidal volume on this guy here? What's that?
I've seen it. I've seen both 400 and 12.
Yeah, and again, here you go. I'm just big boned. Look at the size of lung volume on both those people. They would have pretty much the same tidal volume. So again, ideal body weight. And there are little charts out there where you can guesstimate the patient's ideal body weight, but again, ultimately what it's going to come down to you guys in the transport setting is enough to get an adequate chest rise. And this is one of the old uncorrected tidal volume vents, blah, blah, blah. And again, we want to look at, here we've got a tidal volume of 250 milliliters dialed in for a tidal volume. What we also want to look at is, besides an adequate chest rise, is if your ventilator has the ability to give you what is called an exhaled tidal volume, where we're putting in a 250, and this stands for tidal volume exhaled, VTE. We're putting in 250, what are we getting back? 1/5 of our volume. Is there a problem? We're leaking somewhere. So again, if you can compare inspiratory tidal volumes to expiratory tidal volumes on your vents, by all means also do it. But again, ultimately it's going to come down to getting that adequate chest rise. And then your peak inspiratory pressure, if you're pressure ventilating somebody. Again, we're going to be, the vents will have a pressure manometer on there, which will give you an idea of how much pressure it takes in order to get an adequate chest rise, as well as when you're volume ventilating somebody, besides just writing down how much volume they're getting, write down how much pressure it takes to get that volume. And again, that's all good information. For me being on the receiving end, if you guys come to me and say we're on a respiratory rate of 10, tidal volume of 500, it's taking pressures of about 25 in order to get that. And I put them on my machine and I'm getting pressures of 40, something changed. But again, this should all be part of your documentation. If you're volume ventilating, also tell us how much pressure it's taking in order to get that in. And again, on the pressure manometers, some of them are a little dial with a little needle on. Some of the digital one these days will have a little bar graph on there. If you wind up getting a high peak airway pressure alarm on your vent, it does 3 things. First off, it gives you an audible alarm, it gives you a visual alarm, and most importantly, it aborts that breath. so it doesn't subject the patient's lungs to that high pressure. If you choose to pressure ventilate somebody, again, we have no idea how much pressure to start ventilating these people with. They do have portable pressure manometers where basically you will hook it up in line with a manual resuscitator and start bagging that patient. And just take a good look on the dial there, how much pressure it takes to get an adequate chest rise. And if it looks like it takes about 20 millimeters of mercury or centimeters of water pressure in order to get an adequate chest rise, I'm probably going to start ventilating that patient at with a pressure of about 15 or so, and then just slowly work my way up in order to get an adequate chest rise. And just because the manometer says 20, I'll always start lower and work my way on up. So as far as pressure ventilation goes, 300 million alveoli, all the thickness of a soap bubble. How much pressure does it take to pop a soap bubble? Not much at all. As far as PEEP, positive end expiratory pressure, again, much like the tidal volume, compensated, corrected versus uncorrected PEEP, we also have compensated versus uncompensated. Again, something important to think about. Anytime you've got a patient that you're transporting on PEEP, on the ventilator, one of the first things you should also do is, even though I had said don't bag that patient, but many of the manual resuscitators, pretty much every manual resuscitator that's out there, you can put an external PEEP valve on it. If you've got somebody that's on PEEP on the vent, you should automatically have a PEEP valve on your manual resuscitator. Reason being is if I'm on a high level of PEEP on the vent, and now I have to bag that patient for whatever reason, that same level of PEEP is maintained throughout the entire time. If they're on a really high level of PEEP, down on the bottom here we've got what are called inline suction catheters, where generally in order to suction somebody I've got to disconnect them from the endotracheal tube, and like what I'd said earlier, everything that you just gained you just ruined because you disconnected them. By using an inline suction catheter, you're able to suction those patients while they're still connected, while they're still maintaining their PEEP and maintaining their pressures and their volumes. So if they have one in line, keep it in line, take it with you. Again, it's an airway item, so if you've never used it before, ask how to use it. But going back to the PEEP, is anybody in here using an LTV series vent in transport? You are. Okay, so as you can see, there are multiple different LTVs out there. They all look the same. There are 800, 850, 900, 950, 1000, 1100, 1200, and a 1200 MR. Everything below an 1150 is what is called non-PEEP compensated. And what that means, very similar to your tidal volume, is when we are pressure ventilating a patient, we wind up making alterations to our pressure level to take into account for the PEEP. And I'm not going to get into that too much because, again, you need to know the vent, whatever type of vent you're going to wind up using. Test lungs, which are nothing more than a darn expensive rubber glove, prior to putting your transport vent on a patient, preferably put it on some form of test lung to make sure that it is working adequately. But keep in mind, the compliance of a test lung is much different than that of your patient. So if you're pressure ventilating somebody or volume ventilating somebody, it's going to be a little bit different. And again, know what your resources are, and preferably that receiving intensivist, ICU intensivist, somebody that's used to dealing with mechanically ventilated patients. So the problem children, if anybody knows where I can get one of those t-shirts, by all means, please let me know. Thoracic trauma, again, just looking at this patient's chest x-ray, you've got white-sided whiteout, or right-sided whiteout, left is starting to get a little bit hazy. Again, multiple broken ribs over there on the right side. So besides broken ribs, you might have pulmonary contusion, might be leading to a hemothorax, pneumothorax, we don't know. But that in mind, again, the whole awareness, recognition, management, they tell you this patient's chest x-ray is horrible. So we can just think about, if we're going to be volume ventilating somebody that's got all of this schmutz in there, right, plus a bunch of broken bones, we can just expect high peak airway pressures, poor oxygenation, poor ventilation. Little critters. Preemies, neonates, who's this guy here? Yeah, that is Doc Baker from Little House on the Prairie, where Paul Ingalls would call him out and say, you know what, I need help delivering this calf. So Doc Baker would come out, and then meanwhile, he's heading back to his buggy, and Paul Ingalls says, well, wait a second, Half Pint's got another STD, can you come take a look at her? So you got this guy taking a look at farm animals to, people. Basically, again, as far as these kids go, these preemies, micro preemies, again, it is a completely different world. Again, there's evidence-based medicine out there, and this is not just my shameless plug, but evidence-based medicine out there as far as utilizing specialty transport teams. Where again, I don't want to be on one of those teams that takes a 90-year-old myocardial infarction, and then in the next flight is some 700-gram patient. That is a completely different world. Asthmatics, COPDers, we already talked about this. Don't intubate them in the first place. And that's that hyperinflation phase that we see on these asthmatics and the COPDers where they don't fully exhale. And then again, we got to be thinking about that COPDer that has a CO2 level of 63. Should we get all bent out of shape about that? Then we got to think about what is called permissive hypercapnia or permissive permissive hypoxia. What is their normal oxygenation status? What is their normal ventilation status? Are we going to sit there in some old lunger that has a normal baseline CO2 of in the mid-50s, mid-60s? Are we going to cure that in a 20-minute transport? Probably not. What about circumferential thoracic burns? Over time, what's going to happen to that patient's chest? It's going to get tight. And if I'm volume ventilating somebody where I'm trying to put that 500 milliliters in that chest for every breath, over time, what's going to happen to my volume? Not a trick question. Volume ventilation, what's going to happen to my volume? What's going to happen to my pressure? It's going to wind up going up. And again, over time, it's going to be like trying to ventilate a leather shoe. It's just impossible to get adequate chest expansion. And in the burn unit, where they wind up doing these escharotomies, we'll get these patients that we just get no chest rise because the skin is just so taut. And they wind up doing these elective escharotomies. And you watch somebody's peak air pressures go from the 80s, 90s, down to the 40s, just by cutting them. And then all of a sudden their oxygenation, their ventilation status goes up. Severe CHF. Again, where we've got this fluid in the alveoli where we want air, it's just not going to happen. Not until we get that fluid off. Mr. Farley, we talked about him. Again, ARDS, severe ARDS where you got bilateral whiteout. Again, you can just expect poor oxygenation and poor ventilation. Again, this is one that you want to fight for that driver's seat. Little micropremies, again, you're talking about these little 400, 500, 600 grammars that are intubated with a size 2 endotracheal tube. Completely different world. The red flags, again, if your dispatch center tells you about any of these things, I would kind of perk up my ears. Pressure controlled ventilation, again, if they're at pressure controlled ventilation, there's a chance, depending on the population, that they already exhausted all of their means of volume ventilation. And keep in mind with volume ventilation, I'm going to stress it time and time and time again, your volume stays the same, your pressure goes up. Once your pressure continues to go up and you wind up blowing pneumo after pneumo after pneumo, then we wind up switching over to pressure ventilation. So if there's somebody that's already on pressure ventilation, chances are they already exhausted everything about all of their options with volume ventilation. And again, when you're transporting somebody, get their history, their ventilation history. If they can sit there and tell you, we started volume ventilating and our peak air pressures were in the 20s, then the 30s, then the 40s, then we blew a right-sided pneumo, blah, blah, blah. Then we switched over to pressure ventilation. Nitric oxide. Early on, it was just FDA approved for the preemies due to pulmonary hypertension. These days, though, it's also used for adult patients. But again, it should be a red flag because you're going to be dealing with a sick patient. Prone positioning. Has anybody ever heard about this? So the patients, how often have you seen somebody in the hospital laying on their belly? Why does everybody lay supine? Easier for the healthcare providers. The only mammal in the world that sleeps prone is a sloth. And so as far as prone ventilation goes, basically what's happening is for whatever reason we're not oxygenating, we're not ventilating. Basically we're in a way shunting. We've got perfusion without ventilation or we've got ventilation without perfusion. So somebody thought, you know what? This patient has been laying supine for several weeks. Let's flip them over and see if we can recruit some new areas of lung. And believe it or not, and again, depending on the physician, some think that it's voodoo, and some others buy it. Where you can tell when the attendings change at some of the ICUs because one attending gets on and says, you know what, prone everybody. Another attending comes on and says, flip them back over. But again, if you've got somebody that you're going to be transporting and they tell you in the report they are being prone ventilated, that should be a red flag because chances are they spoke to somebody at a tertiary care facility and said, you know what, you're pretty much at the end of your rope. Try flipping them over, see if that makes a difference. What about ECMO? Basically the heart-lung bypass machine. And again, there are transport programs throughout the nation that actually do this, where you got a patient that is being transported on ECMO, either by ground or fixed wing. There are also some rotor wing programs that also do it. Ultimately, though, what it comes down to is know what your limitations are, especially with the vent. Like I said, I cannot stress it enough. It's that piece of equipment you don't get anywhere near enough training on, but it's the one that will kill your patient. All right, continuing on, if you do have a ventilator problem, again, get the vent out of the equation. The best thing to do is don't just get tunnel vision on that vent, take it out of the equation, look at the whole picture. When in doubt, even though I told you don't disconnect the vent, if you're having a problem with that patient, disconnect and go right back to bagging. Make sure that you're bagging with 100% oxygen. This is going to eliminate that ventilator as the problem. As far as bagging by hand, some people will say you're able to gauge the patient's compliance. Again, that's hit or miss. That only comes down to if you've bagged that patient before. Whereas if you have a problem and now you're bagging them, they're much harder to bag, and you're not getting an adequate chest rise, there might be a possibility of, that tube has changed. Now it's a main stem intubation or possible pneumo or something like that. But if they get easier to bag, again, it's the vent problem. If they get hard to bag with no problem or no improvement, it might be a tube problem, acute respiratory problem, again, like a pneumo or something like that. If it's a rapid onset, chances are there's an acute blockage, be it a tracheal tube plug of secretions or something. Equipment problem, maybe the tubing is kinked or disconnected, or where their settings changed. And again, chances are we're not going to, if the settings were changed, we're going to be the ones that do it. Years ago, we used to have a section of the hospital that was nothing but chronic vent patients. And one of the kids, he would get all of the attention when his parents would come. Well, his sibling reached up and turned the tidal volume on the vent. So now all of a sudden his tidal volume was 80 and now all of a sudden it's up to 400. So again, if it's a slower onset, chances are is that patient's respiratory status is getting worse. And then if you truly have a problem, and if and only if you can confirm the tube placement, take the patient out of the equation, sedate them and paralyze them. Many times you can improve their oxygenation, their ventilation status so much better by paralyzing them. And again, I cannot stress that enough though. Make sure that your tube is in the right place. Where's your mask? And again, this was from the physician that I showed you earlier. Again, this was the way that he wanted you to think about mechanical ventilation. And if you truly think about this, and this is actually breaking it down, breaking that tidal volume down to, or breaking that minute volume down to a tidal volume and breaking that tidal volume down to milliliters per second. If I gave you a concentration of a drug that was however many milligrams in per milliliter, and you were running it at however many milligrams per minute, you would be able to break that down into micrograms per second, correct? By basic math. You can do the exact same thing with mechanical ventilation with your minute volume, your tidal volume, and your inspiratory time. So one of the other things I've been dabbling with in all of my spare time is with mechanical ventilation, since we are seeing this more and more and more and more in the transport environment, what else do you think we're seeing more and more and more of? Going back to saying that ventilator has got the highest probability of killing your patient, but yet is that piece of equipment on your ambulance, helicopter, airplane that you get the least amount of training on. We are seeing more and more and more and more patients that are getting killed or significantly injured with mechanical vents. So over the past couple of years, I've been dealing with these two goofballs, medical malpractice lawyers, that have had issues with transport teams severely injuring or killing a patient. So the things that I tell them to do is many of the newer ventilators these days have some form of data card. Subpoena that card and download it. One of the first cases that I looked at, in a 32-minute bedside to bedside transport time, how many vent changes do you think were made? 28. Let's just turn the knob, press buttons, and see what happens. Do you think if they did 28 vent changes in a 32-minute transport time, they knew what they were doing? Probably not. And then the other thing, the good, the bad, the ugly, and then I don't know if you can read that on the bottom. It says, "Are you effing kidding me?" So the other thing, besides subpoenaing that data card, if it's available, whoever's running that vent or managing that vent, you subpoena their training records. So there is a there is a class out there that's put on by a couple RTs out of North Carolina. They do a 4-day, 4,000 slide, 2-day hands-on class on mechanical ventilation. That's the book. One of our flight paramedics in McHenry took went through this class, loved it, was very confident dealing with the vent. Then he went through that 4-day class, brought this textbook back, and I said, so what'd you think? He said if Ricardo was smart, our medical director, he said he would take the ventilator off of all the helicopters before we kill somebody. He goes, we have got no business managing these things. That's a 4-day class. This is down in the state of Tennessee. If you're going to be doing interfacility transports with an intubated patient utilizing a mechanical ventilator, this is 16 hours of training, 16 hours of classroom, and then 4 to 8 hours of hands-on every year. This is from down in Florida, 2 different air medical programs. The first one is self-directed learning. You get on there and you watch the first one is an 11-page PowerPoint presentation. You watch it, you sign off on it. The other one is 6 pages. You read about the ventilator, you sign off on it. That makes you competent. This is one that I was supposed to teach ventilator theory and oxygen therapy in 10 minutes. I had emailed them back and I said, you know what? I'm going to be able to tell them how to turn the vent on and turn the vent off in the other 8 minutes. I'll tell them some good places to buy clothes so they look really, really good on the witness stand. I said, dude, 10 minutes, I'm going to have to respectfully decline. There's no way I can teach this in 10 minutes. So we talked about CMV, we talked about assist control pressure, assist control volume, SIMV volume, SIMV pressure, non-invasive positive pressure ventilation, pressure support, and CPAP. That being said, medicine is changing every day. I don't know if you can read that, but every one of those, these are all new modes of mechanical ventilation that came out probably within the past 2 years. And now when you sit there you said you use an LTV 1200. Now when you go out and pick up that patient, they sit there and they say, yeah, they're on okay, what mode are you on? Well, they're on LFPPV ventilation. What is that? And again, we are the medical professionals. We are the critical care transport professionals. You are expected to take over this patient's care. And this is where you have to sit there and raise our hand and say, you know what? We don't have 90% of what is on here. However, we've got these modes. One of the nice things about all this crap up here is it is synonymous with exactly what you already have on your vent. Like the one down here, pressure regulated volume control. I can't even find it on here. PRVC, very common in this area. Does the LTV have PRVC? What's that?
We have a new valve too.
So in all honesty, pressure regulated volume control is nothing more than assist control volume. It's just a different name. And again, you're going to have to sit there and ask these outlying facilities, this is what we can offer you. What is the closest vent setting that's like that? And again, I can't stress this enough either. Get your either medical control involved or that receiving facility, their intensivist involved. The downfall with that is now you've got somebody that's not your medical control physician giving you suggestions or orders. So, but like I said, never burn alone. I'm going to skip that. The masks, again, right up there with safety glasses. When I started EMS, we carried that mask and we carried this mask. 99% of the time, which mask did we need? That yellow one, the green one, sometimes even that white one. And it was a volunteer program, and it came down to, well, we got extra money in the kitty. Should we buy decent resuscitation equipment, or should we buy chrome wheel covers for the ambulance? What do we buy? Oh, chrome wheel covers, and we took these very, very, very dead patients to the hospital in a really cool-looking ambulance. So yeah, as far as teaching this, I'm kind of stuck in between a rock and a hard place. I mean, I want to tell you guys, about mechanical ventilation, but it is impossible to teach it in 1 hour, 2 hours, 4 hours, 6 hours. And then there's the thought about, maybe if we had an RT from a local hospital coming to us and teaching us, which in all honesty, we've done that at Flight. But we had an ICU RT come who was extremely brilliant. But now we've got somebody from a hospital ICU setting trying to teach us how to do things in a transport setting. How well does that work? And again, as far as mechanical ventilation goes, you know, in order to actually understand it, you have to sit at that patient's bedside for, you know, hours, if not days, to actually see what happens. So it is absolutely impossible to teach this stuff. And plus, so much of it is region specific. You know, do you think there's a pissing match between Madison and Milwaukee as far as how patients are managed, ventilation-wise? Oh yeah. And there are going to be pulmonologists, and I have seen it. I've seen pulmonologists and critical care intensivists butt heads. You know the little colorimetric end-tidal CO2 devices that change from purple to gold? I had one guy almost in a fist fight saying, well, that's not really gold, that's more of a sandalwood. I'm like, what? Does it really? Again, nobody agrees on anything, especially when it comes to mechanical ventilation. The nice thing is everything that you learned today will be obsolete in a matter of months. So what it's ultimately going to come down to is you guys and girls, when you go back to your facility or whatever program you're working with, and they say, you know, we're going to do vent teaching, you're going to have to speak up and say either, you know, I'm familiar with this, I'm not familiar with this, and let them know that, you know, it's probably not enough education on it. So, any questions at all? And one of the reasons that, you know, when I was talking about all of this legal stuff, when Mark had emailed me and said, you know, are you okay with this being videotaped? Oh yeah. Reason being is because the day will come when somebody does something bad with a vent and they subpoena their training record and they say, well, this dude with long red hair taught me how to use it. And then I get dragged into the mix. I have got a paper trail, decade, you know, years long, that I can sit there and say, I've been bitching about ventilator training for years and years and years and years, that it is no way near adequate enough. So you're going to have to go back to your training director, your medical director, whoever, and say, what else can we do, you know, in order to truly understand this. So this was taken from straight from the ER directly to the operating room. So in the operating room, he has been cleaned up a little bit. As you can see, they did electively trach him, which, how familiar are you guys with trachs? Again, this is one of those things. My first question, if I had to transport this guy, is where was that trach performed? In the ER versus the OR. Reason being is if that trach comes out during transport, which again, in the back of my mind, that is coming out. What are the chances of me doing direct laryngoscopy and intubating him from above? Probably not so good. So the reason I want to know is where was that trach placed, ER versus OR? If it was in the OR and it was electively placed, there's a darn good chance that it was placed in between the second and third or third or fourth tracheal ring. Generally, that's for cosmetic reasons as well as so they can secure it a little bit better. If that trach comes out and I can't get that or an endotracheal tube back through that stoma, what anatomical landmark is left relatively untouched? Your cricothyroid membrane. That is going to be your lifeline. That being said, you're probably going to have to use an endotracheal tube, a cuffed endotracheal tube, and insert it down the trachea past that surgical site. Because if it's not, air is going to take the path of least resistance, which is going to be right out that hole or out into the subcutaneous tissue. So the best thing, just bury that tube as far as you can, even if it's a right or a main stem intubation. So that is what he looked like early on. That's his 3D. And then this is what he looks like today. Well, actually not today, but because he's had actually more surgeries in between. But get rid of this external fixation device. Get rid of that trach site there. You have your choice of managing either the airway on the left or airway on the right. Which one would you want to do? Left. Take the left and run. Again, long before you guys push sedation, long before you guys push paralytics, you have got to sit there and study that patient's face. This is a setup for disaster as far as airway management goes. I mean, what's basically screaming at you? There's a couple things. Grizzly Adams here, he doesn't have much of a Duck Dynasty beard, but is that going to screw up your seal? Possibly. Small mouth, large tongue. However, just looking at his face, you can look at some people and you can know you've had some type of, at one time you've had a burn injury or you've had a skin graft. As far as the elasticity of a skin graft, how stretchy is that? Do you think you're going to be able to adequately open up this guy's mouth for a direct laryngoscopy? Nuh-uh. So now what happens if we sedate him and we paralyze him and we can't even do bag valve mask ventilation? Now we're screwed. And again, are we going to be able to even open up his mouth? I don't know how much that's going to stretch. Again, given the choice between these two, I'd be fighting for that driver's seat. I would want nothing to do with either one of these airways. But now even more so is where was that trach placed? Because, you know, in as far as supraglottic airways, King's combi tubes, LMAs, which again, your airway toolbox should be bottomless. I cannot stress that enough. Again, the chances of him even opening up his mouth in order to get one of those in might be slim to none, but I don't know. Like I said, the more and more I do this, the more and more airways just scare me to death. So, wisdom comes from experience, and experience, unfortunately, comes from mistakes. So, no, all I can say is just sit back and listen and watch everything you can, you know, in the ER, when you guys do your clinicals, rotations and stuff, just be a sponge. I cannot stress that enough. And if you have the ability to go through patient rounds, when the critical care team is going bedside to bedside to bedside, if you can get involved in that, by all means do so. And then also, if you can add your, 2 cents worth, do so, because again, you're talking to a bunch of hospital monkeys that have no idea what you guys do in the pre-hospital or in the transport setting. And if you sit there and tell them that, yeah, this is what we do in the pre-hospital setting, many times they're just blown away. They have no idea that you guys start IVs, outside of a building. It's like, yeah, all the time. So, no matter how much we prepare, again, in this field, you guys have no idea what you're walking into. This is from a nursing home out in Idaho. And like it says, good thing they've got all these fire extinguishers. They got one there, they got one there, got one there. Who would think that a bear is going to come walking in? And again, in your line of work, you have no idea, especially in the transport environment, what you're going to go out for your next call. No clue in the world. Talked about all of this. As far as kids go, again, you either love them or you hate them. I hate them. Can't stand them. There's nothing worse than having we're talking about a population of people that eat their boogers. Now they want to get in your helicopter, they want to try on your helmet, they want to talk on the microphone, they want to press all the buttons. There's not enough Purell in the world. And I had one of my coworkers sit there and say, well, how do you deal with kids? I can't stand kids. And he goes, my pediatric jump bag should consist of some Similac and a funnel. That way I can guarantee they at least get a last meal. Otherwise I have no idea what to do for kids. Awareness recognition, man, we already talked about all this stuff, blah, blah, blah. Again, 90% of your assessment is done just looking at that patient. That's not going to play. See, this is going to be a quick presentation because you've already seen all of this stuff. Okay, but this is one of my biggest pet peeves, not snot. But, we sit there, and this is something that unfortunately we overlook. Once we have the ability to intubate somebody or crike them, that's all we want to do. And unfortunately, we forget about all of the basic stuff. We forget about suctioning. We forget about positioning. And many times, we'll be heading out to a facility and they say, yeah, we're preparing to intubate this child. We get out there, do some aggressive airway management, be it by suctioning or positioning, and all of a sudden that child doesn't need to be intubated anymore. As far as anatomy, again, I don't want to sit there and this is stuff that you all know, but again, we're talking about little bobbleheads here. And when I was making this presentation, I had the pilot looking over my shoulder going, oh yeah, I see you got the pilot, you got the flight nurse, and you got the flight medic. And I'm going, actually, dude, you got the flight medic, you got the pilot, and then you got the nurse with that yippy little jaw that just doesn't shut the F up. As far as the tongue, again, large loss of tone with sleep, sedation, CNS dysfunction. Again, you know all of this. Frequent, if not the most common cause of airway obstruction. As far as pediatric airways, again, extremely high, very anterior. As far as in relationship to the cervical spine, the infant, it's extremely high, located about C1, 6 months of age, about C3, a little bit, once they get older, C5, C6, very, very, very anterior, to the point that you might have to actually kind of get down and look up in order to visualize that glottic opening. And again, there's just in relationship to the C-spine. The epiglottis, floppy, there's not much cartilage there, relatively large in children, and it's omega-shaped, basically like an upside-down horseshoe. Kids are just one massive design flaw. They are built up, they're built for failure, designed for failure. Again, they've got this big old occiput there, so if we lay them down on a flat surface, what happens to their airway? It goes like, how well can you breathe like that? Again, tiny little nares. We talked about decreasing the diameter of anything increases the resistance. Big old tongue, high glottic opening, very anterior, very high, slanting vocal cords in that narrow cricoid ring. Narrowest portion, and again, the upper airway of that pediatric patient is very similar to that of a funnel, where it decreases in diameter, versus that of an adult, pretty much uniform in diameter. Narrowest portion of a pediatric airway, going to be that of the cricoid cartilage. The adult, it's going to be the vocal cords. They say the average size foreign body that they pull out of an adult that completely occludes their upper airway is how big? See about the size of a pack of cigarettes. What's even more amazing is they say normally alcohol is involved. But where we wind up getting burned is with this pediatric airway, is if I'm doing direct laryngoscopy, that looks absolutely normal. But again, what is the narrowest portion? So this was from a 6-year-old years ago that was intubated in the pre-hospital setting. They watched the tube go through the cords. They went to bag and they just could not squeeze that bag. They extubated the kid. Here the entire distal end of that endotracheal tube is occluded with bubble gum. So this kid's sitting there chewing gum, looks out the window, sees a truck coming and goes, aspirates the gum, passes the vocal cords, gets hung up at the cricoid cartilage. Again, direct laryngoscopy, that upper airway looks normal. So I'm going to go ahead and just, so one of my best friends is a pediatric anesthesiologist. Anytime her number shows up on my cell phone, it's just like, oh, cool, what am I going to get? So she calls me and she's like, where are you? And I'm like, I'm in my office. She's like, stay there, I'm coming to you right now. So she's doing this case that she goes to intubate this patient, and she's like, wait a second, something is wrong. And so as far as airway management, again, with intubating somebody, again, much like the vent, you guys are doing a procedure that has got the ability to kill a patient. You need to know that upper airway like the back of your hand. I cannot stress enough. So go ahead and look at this video. She goes to intubate just to take a look, and something just is not right. Let me know if you see something that doesn't look right. So she's like, okay, halt everything. They stop, they call an ENT, they come down and look, and they say, well, you got a big, subglottic cyst. Well, we can either push it in and retrieve it some other day, or we can just get the pediatric Leatherman and we can just go ahead and tear it off. So here comes the pediatric Leatherman. So it's acting like basically a big old ball valve during inhalation and exhalation. So they abort the operation, they go down, cauterize it, and they redo the operation, several days later. But again, looking at that airway, there is your perfect omega-shaped epiglottis. And again, generally, with an extremely high, very anterior airway in little munchkin, newborns, infants, they always say that straight blades work better. And again, I really couldn't care less which blade you use, but with a straight blade, a lot of time in a newborn or an infant, I'll actually use it similar to what they're doing here and actually put it in the vallecula, like you would a curved blade or a Mac. And that just works better for me as well as whoever's doing this intubation. Well, Leanne was, so. Just a big old cyst. So as far as lose them, again, if I'm going to be monkeying around with somebody's airway, have a plan. The mnemonic that I use is lose them, which we'll talk about here that real quick. Where again, every intubation is going to be a failed attempt. What's your backup plan? Where is it? When we go into a scene together or an intubation together, everything gets lined up so we can just go right down the road. But the Luzum mnemonic, this is something that I use for everybody, be it a crash intubation or a conscious sedation, laryngoscope, oxygen, oropharyngeal airway suction, endotracheal tube, combi tube, King, LMA, bag and mask, medication. This is all of the stuff that I want to have readily available within arm's reach if I'm going to be managing somebody's airway. Given the choice out of this entire list to manage somebody's airway, what would you want? So laryngoscope and the endotracheal tube, you guys have seen botched intubations. You've been involved in botched intubations. If you've never missed an intubation, you haven't done enough intubation. Oxygen, even over here in Waukesha, you guys have 21% room air, correct? Hopefully. So if you don't have supplemental oxygen, just start bagging them. Oral airway, again, do a chin thrust, head thrust, whatever. Suction, roll that patient. Endotracheal tube, there's that population of patient that you just cannot intubate. King's, combi tubes, LMAs, keep in mind they have their limitations. Be it a supraglottic rescue airway, if I've got somebody that just drank a gallon of Drano or got pulled out of a house fire with a significant inhalation injury, is that going to do me any good? No. That bag and mask, that's the one that you don't have to be good at that. You have to perfect it. Like I said, that's going to save your butt time and time and time and time again. If you're dealing with little munchkins, McGill forceps, make sure they are readily available, because when you're doing direct laryngoscopy and you see that, oh, hey, there's a Lego down there, is it going to do you any good knowing that your McGill forceps are in the outside compartment? Probably not. Make sure you've got them right there. Oxygen, again, cannulas, adult, pediatric, infant. If you can ever put an infant cannula on an infant by yourself, do they need a cannula? Probably not. If we ever start supplemental oxygen in the ICU, we normally call security and say, yeah, send your 6 of your biggest goons up with a staple gun to hold this thing on, hold this kid down. But if they just freely let you put a cannula on them, something is wrong. Is there such a thing as too much oxygen? And don't go into this whole return of spontaneous circulation after they've been coded, but do we ever really withhold oxygen from anybody? Again, the devices which you guys have used a million times, make darn sure you know the difference between a non-rebreather and a partial rebreather. They look absolutely identical. However, the FiO2 difference is 30 to 40%. There's a hospital that we fly into quite often to take out patients that are actively infarcting. Their entire hospital has got nothing but partial rebreathers in there. So the first thing we do is, oh, we're going there, okay, get a non-rebreather ready. So again, oral airways, nasopharyngeal airways, I only use these about 5% of the time. Reason being is the less amount of crap you stick in somebody's airway, the better. And again, in RSV season, you get these snot-nosed little critters that can barely breathe, and they've got one, not one, but possibly 2 of these in place. Is that going to help them breathe? Majority of the time, we wind up pulling them out, repositioning them. Suction, make sure you've got the biggest, baddest suction on readily available. This was just east of Madison on the interstate that this guy decides to pass everybody in a construction zone, winds up running into that big yellow thing, kills the 2 front people. The guy in the back is unresponsive, just a vomit volcano. We suctioned an entire 500 cc canister of vomit out of him with a little portable suction device, and the whole time I'm taking the Yanker, tapping it on the ground to clear it out, go back into suction, tap it out, suction. MedFlight gets there, they intubate him, they take him away. When I'm cleaning up, I notice that the tip of the Yanker is gone. And so I'm following this guy's progress down in TLC, the trauma center at UW. And throughout his hospital stay, he had this right lower lobe opacification on chest x-ray that just would not go away. So I pulled the attending outside, and I'm like, hey, man, somebody said out at the scene they lost the tip of the Yanker, and this opacification, well, So they call pulmonary, and they bronch him, and they pull out a big old tooth, big old molar out of his right mainstem bronchus. He gets extubated, he gets discharged. 6 months later, calls Mark Hansen, who was the chief flight nurse of MedFlight at the time. He was like, hey, man, I just coughed up this chunk of plastic. Is that normal after I've been in the hospital? Yeah, yes, it is. You're going to be pooping out rubber gloves here, too, pretty soon. The only thing more surprising in this whole talk is there's not an Illinois license plate on that car. Endotracheal tubes, I always have the size. I think I need the next size larger and the next size smaller, with the exception of if we're going to like an inhalation injury. Then I'll have probably the next 2 sizes smaller, readily available. What do you notice about that pediatric one? It's cuffed. Oh my gosh. The cuffed endotracheal tube in the pediatric population is the product of the devil, right? I have only intubated 3 kids in my career with uncuffed tubes because cuffed ones weren't right there. We don't intubate healthy kids. We intubate the ones that just get pulled out of the lake, out of the swimming pool, out from underneath grandma's car tire, out from the house fire. What are their lungs going to be like? Are they going to get better anytime soon? With mechanical ventilation, air is going to take the path of least resistance, which is where? Right up and away. So again, they have got cuffed endotracheal tubes all the way down to a size 2.5 that have been out there for decades. And as far as kids go, if you don't deal with kids that often, if I'm going to be intubating a kid, you know what, this whole age plus 16 divided by 4, blah, 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 don't give me a math problem. A couple years ago, we did a flight up to Racine for a 3-year-old and a 7-year-old. Both of them burned head to toe from a house fire. 3 o'clock in the morning, we get toned out for this, and Sharon said, okay, Stu, what size tube do you want for a 3-year-old? I just crawled out of bed. She might as well have said, you know, Stu, a train leaves Phoenix heading to the east at 80 miles. Meanwhile, a bus leaves. Don't give me a math problem. There's multiple different little cheat sheets out there. This is the one that I carry. It gets me through the first 5 minutes of resuscitation until I can get the eye boogers out of my eyes, wake up a little bit. You guys familiar with this one? Like it, love it, hate it? Braslow tape? So there are some things I like about it. There are some things I hate about it. And doing a lot of pediatric lectures, I'm pretty vocal about it. And our medical director told me, he said, you know, with lecturing and stuff, just be careful. He said, it's like hitting that fire button on a torpedo. You have no idea where that's going to wind up. So I have, in all honesty, I've tossed the Braslow tape under the bus numerous times. This is an email I get. The man, the myth, the legend. And in all honesty, he is like one of the coolest guys in the world that I've ever talked to. And but yeah, so somehow he heard about, yeah, so what exactly were you saying about my tape? So, but being a weight-based tape, this is what we have to take into consideration. Obesity is running rampant nationwide, not only at the adult population, but at the pediatric population. With baby Huey here, do you think that epi is going to hit him, you know, a little bit different compared to, you know, somebody that's height and weight proportional? As far as bags go, infant, pediatric, adult, there have been times we have gone out and they have literally withheld resuscitation efforts because the appropriate size bag wasn't there. Meanwhile, you've got this size bag hanging on the wall. Is there any reason in the world you can't use that on the tiniest little infant newborn preemie? Just tiny, tiny, tiny little puffs. Yeah, not good. And again, as far as the whole intubation, you know, intubate, again, go back to your basic maneuvers. Again, with that big old occiput, there's a classical picture as far as what happens when you put them on a flat surface. What you want to do is get that external auditory canal in line with the shoulder blades. One of the best ways you can do it with a kid, put a towel roll or a rolled up washcloth underneath the shoulder blades to take up that void. And then again, basic maneuvers, positioning, suctioning, bag valve mask. Again, should be a 2-person job. You know, in the hospital, being a spoiled rotten hospital brat, we press a little blue button on the wall. How many people come running? And that's when half the staff calls in sick. Now, in your environment where you've got 2 people in the back of an ambulance, 1 person thumping on the chest, you know, you don't have this luxury. Max versus Millers, curved versus straight. If you want to be a purist, there's about 300 different types of laryngoscope blades out there. Basically, anytime an anesthesiologist makes any alteration to a blade, what do they do with it? Or put their name on it, yeah. So curved, straight, blah, blah, blah. Again, 5 different size straight blades from a 0 to a 4. And unless you guys get called to the Milwaukee Zoo every now and then to help intubate a giraffe, that's somewhat overkill. And again, you're going to be going down, picking up the epiglottis itself, lifting it up and out of the way. Curved, there's, you know, up until several weeks ago, I thought there was only 4 sizes of Max. There's actually a Mac 5 out there, which same thing, really, really, really big blade. And again, going to be going down into the vallecula, lifting up and away. That being said, if I take a Mac and pick up the vallecula, who's going to know? Or if I take a Miller and go in the vallecula, who's going to know? Only me. And when I first started intubating, every other patient I just went curved, straight, curved, straight, curved, straight, just to get proficient at both types of blades. Because the day will come, I guarantee it, when your favorite Mac 3 is all filled with blood or vomit, and somebody hands you a Miller. Little munchkins, if you can beg, borrow, steal. There's a cross blade out there. It's a combination of a Mac and a Miller. It's called a Robert Shaw, made by. Guys are sharp as the edge of town, your class mark. As far as intubation, again, something as far as maintaining proficiency on it, we sit there and we spend hours and hours and hours and hours on Fred the Head, learning how to intubate somebody. I've never intubated anybody that's got that nice plastic airway. And a couple of years ago, I was doing this lecture, and coincidentally, the day before I gave the lecture, Michael Jackson died. And I said, I've never intubated somebody with a plastic airway. And I'm thinking there's probably some medic out in California that can say, well, I did. Go to Google, and up on the top it says web, it says images, it says maps, shopping, video. Type in vocal cords and hit enter. It is like RT porn. You're going to see 200, 300 pictures of upper airways taken by video laryngoscopy, bronchoscopy. I will sit there for hours just looking at real airway pictures instead of a piece of plastic. Again, you need to know what normal anatomy looks like before you go after the abnormal stuff. Here again, there's your vocal cords. There's your cricoid cartilage and your subsequent tracheal rings. Again, here's that pediatric airway, that funnel-shaped airway. Here's an infant with that, again, that classic omega-shaped epiglottis. So those were all normal airways. This is a patient that just had what appears to be somewhat of a significant inhalation injury. And again, in your line of work, you've got to be thinking about into the future. What is this patient's airway going to be like 5 minutes, 10 minutes, 15, 20, 25 minutes from now? If this is an inhalation injury, what's going to happen? It's going to swell. And these, we were always taught less than 8 intubate. Why is it 8? As far as their GCS. More important than that. That's the only number that rhymes with intubate. These are the patients that are going to have a Glasgow of 12, 13, 14, 15 that are going to be talking to you, and you say, you know what, to the closest facility, it's 20 minutes. Is this patient's airway going to last 20 minutes? We don't know. But do I want to be that medic in the back of the ambulance that has somebody that's getting more and more stridulous and they wind up losing their airway? These are the patients that I would much rather control their airway sooner than later. Because if the airway completely occludes, again, is your supraglottic airway going to help you at all? No. Same thing here. That's the epiglottis. You got probably about a 20-25% field of view of that glottic opening. 20 minutes from now, that's going to be gone. Eschmann stylet or gum rubber bougie, you guys using these? Familiar with them? One of the original flight nurses, Blake, from Waukesha, called me years ago, and he goes, had one of the worst airways of my career. He goes, I almost thought I'd have to use a bougie. And I'm like, really? I said, how many times have you ever used it? He goes, never. And I said, okay, so let's just back up a little bit. So you got the worst airway of your career, and you're going to use a piece of equipment that you've never used before? I said, from now on, for all of your elective or emergent intubations, I would use the bougie on absolutely everybody. Just make it secondhand. That's so when you do have that nasty intubation, it's a tool that you've used multiple times before versus grabbing some piece of equipment that you've never used before. And the bougie, keep in mind, it does have its hang-ups, where again, going back to somebody like this, we might be able to pass the bougie fine. However, we're passing a larger diameter tube through that glottic opening. What are the chances of that tube getting hung up? There's definitely a chance. And if it does happen, remember the rule of thumb is you want to do a counterclockwise rotation with the tube so it doesn't get hung up on the arytenoid cartilage. There is a better mousetrap out there. It's called the Radlin stylet. It's a cuffed stylet, where again it's a tapered stylet, so it's like a hot knife going through butter when you use it for somebody like that. What's that? So that is the epiglottis. This is epiglottitis. That being said, what's that tiny, tiny, tiny little dot in the middle? So that is the glottic opening. So again, this is the fight for the driver's seat. And these are the patients that generally bypass the ER and go directly to the operating room. This is epiglottitis. That's probably not going to play. Smoke inhalation, where you can visibly see some anatomy, however it is darkened due to the soot on there. But again, you need to know what that upper airway looks like so you have some idea what to go for. And as far as confirming tube placement, we always talk about end tidal, end tidal, end tidal. The little colorimetric ones that change color, those ones, they are by far the most accurate. They're probably the most commonly used ones also. But all that being said, they're used the most because they are the cheapest. And as far as if you read all the studies, where were all of the studies on those done? In the OR, where these patients have been NPO since midnight. Now, when you guys pick up somebody off the side of the road on one of the nights that the Packers win, what's in their belly? Beer, or you go to the local skate park with little munchkin, non-helmeted, just drink a 6 or Red Bull and washed it down with Mountain Dew. Now you inadvertently intubate the esophagus and you get a rush of gas back. That thing changes color. What makes carbonated beverages carbonated? So now that thing changes color. Is it lying to you? No. Is CO2 present? Yeah. But the downfall is, as far as technology, you can either embrace it or you can run from it. The downfall is some people embrace it too much. And instead of going back to our basic patient assessment, they're sitting there looking at this stupid little colorimetric device. And they say, well, that thing changed color. My tube is good. Instead of doing a full assessment, negative epigastric sounds, high bilateral breath sounds, and then capnography waveform. And by far one of the best things you can do is actually just go back down and do direct laryngoscopy and visualize that tube going through the vocal cords.
I often think that you could be the best paramedic in the world and have all the tools you want, but if you don't go back to the basics to begin with, it's good for your patient.
Thank you. Yes. Yeah. Eventually, you know, it'll be to the point where we're not even going to have to touch patients because we got them on the automatic blood pressure cuff and we've got, you know, video laryngoscopy and all of this other stuff, and yeah, it's just unbelievable. Yeah, you know, and same thing with the automatic blood pressure cuffs. If you can't even take a blood pressure manually, you know, again, just the basics. Kids, in a nutshell, if it's not chained to the ground, if it's not bolted to the floor, what do they do with it? So any acute onset of respiratory distress in a pediatric patient, you can pretty much assume it's a foreign body until proven otherwise. So again, if you're going to be monkeying around with your airways, make darn sure you got the McGills readily available. Probably the most common thing we pull out of kids is what? Yeah, they're just ambulatory little piggy banks. A Monopoly toy sitting right above the crina, again, not supposed to be there. Acute onset of stridor that goes away pretty much as soon as it came on. Getting a little bit more of a history, what they find out is, he was playing with a wood screw, which initially was caught up here in his upper airway, creating the stridor, and then he inhaled. Now it's all the way down here in his right mainstem bronchus. And the kids are stupid file. This is a 13-year-old that walked into an ER down in Denver. He couldn't speak. He had brown sludge coming out of his mouth. And his friend said, well, here's the deal. We were fishing, and I bet him he couldn't swallow that 8-inch perch that he just caught. So fish bones are going to show up just like human bones. So here you got the fish head. Here you got the tail and the posterior oropharynx. Well, the doc's like, oh, no reason, no worries. That's why they make McGill forceps. Well, I'm not Babe Winkleman, the fisherman, or anything, but perch have these spiky dorsal. So yeah, grabs the tail and gives it a big old yank, and embeds the, what are they called? Whatever, embeds it where it's not supposed to. So they wind up taking him to the OR. They crike the kid to give him an airway. They cut the dorsal fin off the fish and then pull it. What about somebody that's in full C-spine immobilization? How easy is it to do direct laryngoscopy with somebody like this? You know, it can be done, but generally it's a 2 or 3 person job. Pop that collar, pop those SID blocks, have somebody maintain manual C-spine stabilization from the front. This guy up here is actually doing cricoid pressure with his thumb for me. Get that tube in, confirm tube placement, secure that tube, and then put the C-collar back on plus the SID blocks. Again, never burn alone, blah, 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 blah. So yeah, as long as I still got you for a couple minutes, someone made a comment about the trach. We're going to chat just a little bit about them, just because as far as airways, as far as ventilators and stuff, there's kind of a trend here. They make me nervous, extremely nervous, and the more prepared you can be about some of this stuff, the better. So as far as the trach, I told you that's in there every day, blah, blah, blah. So when I went through paramedic school, we sat there and we learned how to intubate people nasally, orally, digitally, all this good stuff. And I said to my instructor, I'm like, well, I said, what about the patient with a trach? Because at that time I was working as an RT, and we were sending people out, not only adults, but kids and adults, out to the community every week with trachs. And this is what she had said: you have a better chance of picking up Elvis than a person with a trach. So So there was, brand new paramedic, just off orientation, we get toned out for a motorcycle accident. What was different with this patient? No.
Come on.
Yeah, that's fake. So as far as kids, again, fighting for the driver's seat, rectal bleeds, childbirth, anything with a trach. You want to see a bunch of grown adults fight for the driver's seat of the ambulance. If you get toned out for any of that stuff, I guarantee you, the last thing I want to do is deal with any of that stuff. And this used to be my MO. I used to sit there and if we had any of that stuff get toned out, I would be the first person in that driver's seat. And how well did that work when I started flying? Yeah, it went over like a fart in a phone booth. It's like, yeah, that's not going to happen. And when I started, they said, well, you're the medic from Wisconsin. What do you guys do up there, trach cows? And it's like, well, actually, yeah, if you do have a trachea, you can trach a cow. I talked about this again, preparing for the unexpected, talked about that. See, very, very short lecture here. So as far as what we're going to do, we're going to talk about the different types of trach tubes, identify trach emergencies, pre-hospital management, as well as transport management, and then just basic suctioning. Again, these things have been out there for decades and decades and decades. Anyway, we talked about upper lower airway heat humidify filter, blah, blah, blah. Talked about that. There's that little classic towel roll. Okay, let's talk trachs. What's the difference between a high-tech kiddo and a terrorist, the parent of a high-tech kiddo and a terrorist? You can negotiate with a terrorist. How many people have dealt with a parent of somebody, a special needs child? Yeah. So when you come in there and say, you know what, this is the way we're going to do it, what does mom or dad say? No, you're not. And there you go. So we have a frequent flyer down in the McHenry area, a little girl that's got what's called spinal muscular atrophy. Her mom will carry her into the triage desk at the hospital and say, I need your helicopter to take my daughter down to Children's Memorial in Chicago. She will sit there and say, Sharon, you're the nurse, you're going to sit there, your job's going to be this, 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 and this. Stu, you're the medic, you're going to sit there, your job's going to be this, 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 and this. I'm going to sit right here. My job is to bail you guys out when you can't figure it out. And I had the pilot sit there and say, oh my gosh, I thought she was going to tell me. And you're the pilot, you're going to talk to O'Hare Tower on 127.9. But this lady deals with that child 24/7. I see this child once every 3 years. Do I know more than mom? Never. So a couple of years ago, I did a lecture for an EMSC conference, and I took a couple kids from the Children's Hospital, invited their parents as well as their home health care nurse, and we talked about children with special needs. And on one side of the table, we had the pre-hospital providers, and on the other side of the table, we had, again, the family members plus a home health care provider. It was just unbelievably, because I said, okay, Connor here, who Connor has got spinal muscular atrophy type 2, I said, he coughs his trach out. These parents, this home health care nurse who has put that trach back in emergently dozens and dozens and dozens and dozens of time, if they can't get it in, what are you guys going to do? And they're like, well, we're going to call 911. Okay, what are they going to do? Well, they'll probably come, they'll probably start an IV, they'll probably sedate him and paralyze him and probably orally intubate him. And these guys are so far west, they're almost to the Mississippi, and so they're out in literally more or less Pumpkin Hollow. Where again, Wisconsin being 85% basic EMTs, now when I tell mom and dad that, you know what, they're not starting any IVs, they're not giving any drugs, they're going to be doing basic airway managements, what do you think they said? Do you think they freaked out? And the thing is, they weren't freaked out more than the people over on this side who were the first responder EMT basics. They're like, wait a second, this ticking time bomb is in our community and we know nothing about him or her. So as far as tracheostomy, temporary opening into the trachea, surgically placed below the level of the cricoid ring, and we talked about that due to securing it better as well as cosmetic purposes. Stoma, again, opening into the neck, created for that tracheostomy itself. And again, due to cosmetic issues, there are so many things out there where, you know, if you're talking to somebody that's got a stoma, what are the chances of you looking down at that stoma and staring at it? These days, they've got all sorts of things to cover those things up with. So you might have to go searching if you can't get an adequate seal with your bag valve mask because there's some piece of fabric going like this underneath their chin. Chances are they have a trach. So why a trach? Vocal cord paralysis, inability to handle secretions, head and neck differences, spinal cord injuries. unable to maintain a functional airway, laryngeal cancer, as well as long-term mechanical ventilation. And there's that spinal muscular atrophy. And again, kids, adults, you name it. Teenagers, little munchkins, all the way down to these tiny, 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 tiny little kids. And again, it might not be an interfacility transport. It might be you guys getting called out to a 911 call, where again, these days there are more and more specialty transport teams out there. There might be that possibility of one of those specialty transport teams transporting a child or an adult with a trach, and they wind up upside down in the ditch, and now you've got to take care of them as well as that patient. That's what happened down here in Arkansas. Okay, frequent speed bumps with the trach. Again, when you bypass that upper airway, again, in order to talk, air has to go through my vocal cords. If I have got a trach and I bypass the vocal cords, how do we talk to these people? And there's multiple different things out there. The little typewriters, you've seen the little, I'll probably go to hell for saying this, but they call them the cancer kazoos, the things they talk with, and it vibrates their vocal cords. As well as a couple different speaking valves that are out there. In a case like this, and basically the patient will inhale through that, and then when they want to talk, they'll put their finger up, they will cover up that opening, and then the air gets forced to go up through the vocal cords, and then they can go ahead and speak. They're not going to be able to sing, songs or anything, but they can speak to you in one word, 1-2 word sentences or so. As well as there are also what are called fenestrated trachs out there that have got a hole on the back, where again, they can either plug that, and again, the air is forced to go up through the vocal cords and then out through the nose and mouth, and they can go ahead and speak. Speaking valves, they attach to the trach itself simply by friction. It's a little one-way valve that when they inhale, it opens up that valve, very similar to that of a, kind of like a little valve on a non-rebreather. And then when they exhale, it forces that valve closed and forces the air to go up again through the vocal cords so they can speak. The thing we need to keep in mind is with that speaking valve on there, what is it blocking? It's blocking our ability to bag that patient in an emergency. So keep in mind, those are held on there just by friction. You're going to have to remove those, and then you can go right back to your manual resuscitator ventilation. Same thing, that's going to have to come off. And this one actually has got, so this is a speaking valve, plus he's got supplemental oxygen attached to it. Other things is, again, secretions. We talked about this a little bit earlier, is we need to keep those secretions heated and humidified. If not, they wind up turning into rocks. So generally, these patients that have a trach, since their upper airway is bypassed, they're on some form of artificial heated humidity. The downfall is this little kid, do you think he wants to be stuck on a heated humidifier all day? No, he wants to be outside playing around. So they take themselves off, they become dehydrated, the secretions become rock hard. There are also what are called artificial noses, which they're about the diameter of a quarter, and inside there's this little, almost like expensive crepe paper, that when the patient inhales, it winds up going through that artificial nose, but when that patient exhales, again, when we exhale humidity, it saturates that paper that's in there, and then when they inhale for the next breath, it rehumidifies. So it's called an artificial nose or a heat moisture exchanger. The downfall with these is after about 45 minutes, an hour of usage, they become extremely soggy. And when they become soggy and saturated with secretions, what happens to resistance? So again, they need to be changed. And again, just like those speaking valves, in an emergency situation, that gets in my way when I have to bag that patient. Same thing, those are held on there just by friction. Just go ahead and rotate them off. And we talked about that. Different types of trachs. This is a whole day-long lecture. Up on the top, we've got some of the larger diameter trachs. Down on the bottom, we've got the smaller trachs. One of the big differences between the larger diameter trachs is generally they have got what is called an inner cannula, which we're going to talk about, which is basically a tube within the tube. Downfall of some of these smaller trachs, they are such a small diameter to begin with. If we wind up putting yet another tube inside there, the diameter is so incredibly small and the resistance is so incredibly high. But the pre-packaged trach tubes, you're going to wind up getting the trach itself. Again, these are what are called the inner cannula. You're going to get what is called the obturator, which is something that you definitely need to have with you. And then you also get what's called tool tape, which is just a darn expensive shoelace. As far as the single cannulas with the obturator, and again, this is such a small diameter tube, there's no way to put yet an additional inner cannula in there. And again, all the way down to tiny little neonatal trachs, it might have an internal diameter of 2 millimeters. That being said, the smallest amount of secretions can partially, if not fully, occlude that trach tube, which in these cases, secretions can be a problem, If you have dried out secretions that completely occlude that trach tube, you have to either emergently suction or take that trach tube out. Whereas the larger diameter trachs that have got that inner cannula, if I wind up completely occluding that inner cannula with secretions, I can pop out that inner cannula. My patient now can at least spontaneously breathe. The downfall is that inner cannula, that is going to be your lifeline to connect to that manual resuscitator that needs to go back in. And these are those inner cannulas that I just spoke about. But like I said, with that taken out, you can't hook a manual resuscitator up to it. And these are held on a couple different ways. Some of them have got little claws that you have to pinch together in order to remove it. Other ones you've got to rotate it probably about a 90-degree counterclockwise turn, and they do snap in place. Some of the information that I would love to have being on the receiving end, if it's a trach problem and you don't have a backup trach, is up on the wings of the trach. This is a Shiley, it's an uncuffed, it's 4.5 pediatric. That's all nice to know. The need to know is what's over here. This is a 4.5 millimeter internal diameter, and it's a 6.5 millimeter outside diameter of the tube. As well as also, if you can really help us out, also give us the length. Reason being is if I don't have a 4.5 Shiley in stock, I'm going to get the next closest thing. This one is a Shiley 4.0 cuffed one, 4.0 inner diameter, 5.9 millimeter external diameter. And again, so you got the internal diameter, the outside diameter, and then you've got the length. And if we don't have that particular Shiley in stock, we're going to give you the next closest thing. So assessment interventions, no different than an endotracheal tube. If you've got a problem, we always use a doped pneumonic, dislodged, obstructive pneumothorax, or is it the equipment problem? Again, dislodged, get right back to that patient's airway. And again, with the stoma, there's two different patient populations. There's those stomas out there that as soon as that trach comes out, those things close pretty much immediately. Then there's the ones like this kid here that stoma comes out, he doesn't even know it. So as far as why they become dislodged, again, positioning, when the trach ties are too loose, kids want to be kids, they untie it. Weight changes, again, if you've got a heavy circuit, a vent circuit hanging off there, or cuffed trach problems, much like an endotracheal tube, never assume that that cuff has anything to do with securing that tube or anchoring that tube in place. The only thing the cuff is there for is to create that seal. The purpose of a cuff is not to anchor or secure a tube in place. So again, the questions I always ask is why do they have it, and then second is or first off, what happens if it comes out? Again, what happens with that stoma? And if you've got that home health care professional, that mom or dad that sits there and says, oh, that stoma shuts immediately, that's good to know. And then why do they have it, and is it needed? If it comes out, is that stoma going to close immediately, or do I have to put a tube back in, or can I take my time? As far as inserting a trach tube, again, positioning is everything. And everybody that has a trach also has some form of what's called a ready go bag or ready to go trach set, that everything is ready to go, and we'll show you that here in a second. Suction equipment if you do have a lot of secretions, bag and mask. And there's that go bag where pretty much everything that you will ever need is in that bag. And generally, like I said, if they have a trach, they should have that with them. Multiple different size trachs, bag and mask, where again, the mask, not so much for doing bag valve mask ventilation over the mouth and nose, but to do bag valve mask ventilation over the stoma. Unless you have some strange, fetish to do mouth to stoma ventilation. And then there's that classic towel roll that we're always going to have. And then we want to lubricate with some form of water-soluble lube, be it Surge Lube or KY Jelly. And if you don't have it, just go ahead. Saline water is fine as well. Should be a two-person job. Again, use that towel roll. One person to go ahead and spread apart that stoma, lift up the chin. And there they've got that obturator in place. Here they're kind of, I don't know if they're, no, that's just part of the trach tube itself. And when we sit there and we practice as well as prior to those patients going home, the caregivers get hours and hours and hours and hours of changing a trach on somebody like this, on these dolls. The first person you have to emergently change a trach on, are they going to look like this? No, it's going to be this guy here, or worse off, somebody like this, where somewhere underneath that 13th double chin, there's a stoma, and that trach needs to go in it. Again, if you meet resistance, go ahead and stop. You might have to reposition, relubricate. This is the daughter of one of our paramedic instructors down in Illinois who had Guillain-Barré. She was electively trached, and I was talking to her. So she was trached, mechanically ventilated for a prolonged period of time, and I asked her, what is it like to be trached? Tell me. If I'm going to be teaching this stuff, I don't want to be trached, but I want to be able to discuss it. And she said one of the worst things was trach changes. And she said they had some people that just put so much pressure down, she thought that they were breaking her neck. So these are, images taken from bronchoscopy of a trach. This is a percutaneous trach that's being placed at the bedside, but there's those cartilage rings, the C-shaped cartilage rings in the airway. Here they're putting it in, and here you can see what happens with pressure. And she said that's what it felt like every time, is that they were just completely occluding her airway by putting down so much pressure. If you're putting down so much pressure, there's a problem you need to stop. As far as that obturator coming out, again, we're putting something in somebody's airway. Anytime anything foreign goes in somebody's airway, what's the body's first thing to do? It coughs. So you want to make darn sure that somebody's holding that trach down, because otherwise you're going to have to go all the way to the other side of the room, pick up that trach off the floor, bring it back in, wipe it off, and then put it back in. So that obturator, again, make sure somebody's holding the trach. You're going to use the obturator just for inserting the trach, and then go ahead and remove it. And then they're inserting in the inner cannula. And keep in mind, you're going to need that inner cannula to hook up to the bag or the vent itself. And again, much like placing an endotracheal tube, we're going to confirm breath sounds as well as capnography, much like an endotracheal tube, after we go ahead and place that trach back in. If it's cuffed, go ahead, much like an endotracheal tube, put in just enough air to create a seal. Securing it, use a tool tape and tie it in place. And again, as far as fashion goes, kids these days, here you got the Mr. T starter set, and then you got the environmentally correct hemp biodegradable ones. If you don't have twill tape or whatever, just go ahead, steal a patient's shoestring and tie it in place. That will work just as well. There are also commercially available devices, much like the endotracheal tube holders, that are just Velcro, fairly simple. If by chance you can't get that trach back in and you have to go ahead and secure an airway, again, you can do bag valve mask ventilation from above, covering up the stoma with a piece of gauze. For an adult, same thing with a kiddo. And again, if we've got trach problems, we're going to get there and we're going to do the exact same thing the parents did. We're going to attempt ventilating. We're going to attempt ventilating with a mask. We're going to attempt suctioning. We're going to attempt bag valve mask ventilation from above. However, if you don't have that stoma occluded, air is going to take the path of least resistance, which is right out through the stoma. And then one thing that's really going to throw a wrench in the works is there's also a population of patients out there that have what are called complete trachs or complete laryngectomies, where these are patients that are chronic aspirators, where everything in their mouth, be it secretions, whatever, goes directly into the lungs. They spend countless days in the hospital with repeat pneumonias, where after a while, they sit there and say, you know what, we're going to close off the bridge. We're going to close off the upper airway to the lower airway. And they literally sew the glottic opening shut. That being said, if I attempted to do this, where would my air go? Right to the belly. And then here they're talking, again, this is in the, when you're in the dire straits mode, where you can take a suction catheter very similar to that, like a bougie, stick it through the trach, stick the suction catheter through, and then thread the trach over the top. The downfall is if they're to this point here, that stoma site is going to be so traumatized, so edematous already, that the chance of this passing over is probably going to be slim to none. This probably isn't going to play, but if all else fails, has the child do it. Decannulation, meaning that it comes out, again, basic life support first, go ahead and bag, and then again, you can always go ahead with an endotracheal tube. And then last resort, orally intubate. However, again, if they've got that complete laryngectomy, you're going to go down and do direct laryngoscopy. You're going to come across a tissue wall. As far as inserting the endotracheal tube, generally we don't cut them off. Some people will cut them off to decrease the amount of dead space. If you just emergently recannulated somebody with an endotracheal tube, are we really going to worry about the small amount of dead space? Probably not. And again, somebody needs to be assigned to that tube so it doesn't come out again. They're not going to help push the stretcher or lift or anything. They're going to be, like I said, strictly dedicated to that. And again, no different than placing an endotracheal tube in somebody, with the exception of how deep you stick it. Don't stick it 3 times the diameter to the stoma, because where are you going to wind up? Probably down in the main stem. Again, shouldn't be any resistance, equal chest rise and fall, equal breath sounds. Improved vital signs, capnography, as well as colorimetric if needed, pulse oximetry. Blah, blah, blah. We're not going to go through that. As far as suctioning, again, don't be burying that suction catheter. Generally, the rule of thumb is only suction to the depth of the trach itself. So again, probably about 70 millimeters or so. And many of the suction catheters have got centimeter markings on there, so about 7 or 8 millimeters, 7 or 8 centimeters. Obstruction, again, we talked about this a little bit earlier. Generally, if you have a truly obstructed trach tube, first thing you can do with that cuffed or that trach that's got that inner cannula, just go ahead and replace that. If you've got a child that has got a obstructed single cannula trach tube, that's going to have to be changed immediately. Then again, a good rule of thumb as far as how deep to suction that patient. You can also use the obturator as a guide as far as how deep to insert that suction catheter. And again, you guys know how to suction. I'm not going to sit there and beat a dead horse to death here. If you do have to remove a trach, again, this is something that should be last resort, especially in the pre-hospital section, even the transport setting. This is the absolute last thing in the world I like doing, even in a hospital where I've got surgeons, ENT surgeons right there and ready to go. Again, a several person job. Get that towel roll in there, have somebody get that chin out of the way, lubricate. And here with the cuffed one, much like an endotracheal tube, they're just dropping the cuff and then removing it, cutting the twill tape, and putting it back in, and there you can see the obturator in place. And there they're suctioning and attempting, I should say, the second type of obstruction is where you've definitely got a blockage there. And there what they're doing is just squirting a couple drops of normal saline down there to see if they can break that up, loosen it up a little bit. And again, if that doesn't work, then you're probably going to have to emergently change that tube itself. Okay, all basic suctioning stuff, which you guys know. Again, pneumothorax, that's probably not going to play, so I'm not even going to bother with it. Same thing there. You know that, you know that. Emergency treatment for a pneumothorax, what are you going to do? Needle them, and you're going to, hear this huge rush of air, and you're going to see, unicorn ponies that fart glitter and all that other good stuff. I don't know how many times I've decompressed a pneumo. I've never heard that rush of air with the exception of this one time. And we decompressed him, and there was such a rush of air, as well as I looked at the ceiling of the helicopter. That's how much pressure was in that guy's chest. And so I yelled at the pilot. I'm like, don't clean it. I need a picture of it for class. So I did that just for you guys. As far as the equipment goes, again, multiple problems. When replacing that trach, this is why it is so incredibly important to check capnography as well as breath sounds, is because we can stick that trach down into the stoma and we can create a new pathway where we assume it's in the trachea, where in actuality it's down in the subcutaneous tissue. And that's what's happening here. You've got your trachea here, and here you can see the trach tube itself is kind of migrated off to the side where they created a new pathway. We talked about all of this stuff. There's anytime anybody with special needs goes into the community, the American Academy of Pediatrics as well as the American College of Emergency Physicians came out with these little cheat sheets that if you've got repeat offenders, hopefully that they have contacted the ambulance service and said, my child, a daughter, whatever is going to be in your community, this is what's wrong with her, this is where she winds up going, or he goes. So if you get called out to that address, you know pretty much exactly what you're walking into. We talked about all of this stuff. So again, with these special needs kids, especially if they've got a trach, if they have a trach they should have a backup trach somewhere. There's also a population of patients that have got what are called custom-made trachs, where there are generally two of them in the world, one of them in their neck, the other one's usually taped to their bedpost or something. Make darn sure that comes with you. We had one repeat offender that he would come in constantly with trach problems, and I would always ask him, I'd say, Bernie, where's your backup trach? Taped to the bedpost. What good would it do us back there? So take the backup trach. They should have the correct size as well as one smaller. Same thing with suction catheters. Take only as what you need. And we already talked about this a little bit earlier. Talked about that. Oh, this is so. As far as trach problems, this is a cabbie down in the Gurney area that he was robbed by his cab fare. Shot him left, right, and back side of his neck, and his lower lip and jaw, and the upper middle portion of his back. So we had to take him from Waukegan to Libertyville. And anyway, when we got there, he had just had upper airway surgery. His jaw was wired shut. He was trached. And again, being the pessimistic person I am, that trach is coming out. That being said, with a wired shut jaw, am I going to be able to do direct laryngoscopy on him? Plus, if I was, he just had recent upper airway surgery. There's no telling what I would be looking at. So again, this is where you need to talk about where was that trach done, OR versus ER, and we just talked about that a little bit earlier. If it's the ER, it's probably your cricothyroid membrane. That being said, that is now going to be your lifeline.